In today's video, we have a master class on rotator cuff related pain and rotator cuff tears. Kevin Coughlin and I have a combined 17 years worth of physical therapy experience, and we go through 94 different references to give you the most up to date information on rotator cuff related pain and tears. And we've consolidated all of this into a 2-hour video for you. The first part of the video goes over 4 keys to non operative treatment for rotator cuff related pain. Without further ado, get to learning. So, I think that the most important thing to start with your patients is making sure that you have an accurate diagnosis. Because if you're treating the wrong thing with the wrong treatments, then you might not make any progress, right? So, I think that's important. I don't think you need to be super specific with your diagnosis. I don't know that we need to know exactly like this is a supraspinatus tendinopathy, and it's not like an infraspinatus or biceps tendon. But I do think you have to rule out weird pathologies that have a different treatment. And I think the big one that I'm thinking about for most patients go through door is going to be radiculopathy, right? Is there something going on with the neck that's creating shoulder issues? And I think the big one is like a C5 radiculopathy, because these folks tend to have pain around the shoulder region, which is usually where folks have rotator cuff related pain. They'll often have some weakness in the deltoid, which you see with these large and massive rotator cuff tears, right? You see a bit of a shrug sign in those folks. So just make sure that you're not dealing with some sort of cervical radiculopathy. These are funky because oftentimes the arm pain is worse than the neck pain. So sometimes the neck doesn't hurt and we've got a bunch of arm pain, and it ends up being something neck related. But rule that out first. The second one is going to be some sort of frozen shoulder. Just because frozen shoulder is generally treated with range of motion, oftentimes a cortisone shot is really helpful. Maybe you want to call the doc back up, get him back in for a cortisone shot before you start with physical therapy. And then your exercises tend to be more flexibility based. Although flexibility is also helpful for rotator cuff related pain, you're probably going to do more range of motion for a frozen shoulder than you would for some sort of rotator cuff related issue, right? To go along with this video, I have a free cheat sheet for you. It is an evidence-based cheat sheet for rotator cuff related pain. I'll give you all the knowledge to go from a beginner to a master understanding rotator cuff related pathology. We go over the prevalence of these conditions, as well as the anatomy. We talk about the difference between tendinitis and tendinosis. We chat about risk factors increase your likelihood of getting rotator cuff tendinopathy and tears. We talk about the clinical presentation of this disorder and also which tendons are most commonly involved. We talk about the different stages of pathology and whether or not the rotator cuff tear heals over the course of time. Next, I give you the bullet points about rehabilitation expectations. We round out the PDF with some surgical guidelines, which your patients should go on to get surgery for rotator cuff tears. So I'm going to leave a link in the description, in the show notes. Again, this is 100% free. Go ahead and download this right now.
Yeah, I'll just add in here that, having worked with you for a while, I'll say that you truly do check these things on people. I'll overhear you and, I've tried to pick up the same patterns, right? But someone comes in with, sometimes we get fooled by a script. So someone might come in with a script that says rotator cuff pain or subacromial impingement. And a lot of times it's easy to just assume that's what's really going on and get right into treatment and talking to the patient about what this could mean for them. But you do really want to be thorough here. And, I'll often hear you ask the patient if they have any reason to believe that this pain is coming from their neck, any history of neck pain. So get a little subjective history with that. For frozen shoulder and in that type of diagnosis, maybe they have some comorbidities that we want to look into. Diabetes, some type of thyroid issue sometimes can predispose people to that. So we do want to be thorough in the subjective. And then one thing I tell our students often, and I know you're really good about this, is when we go through the objective assessment, we always want to start top down, right? So if I see someone with a shoulder pathology, we're screening their neck. We're looking at all the cervical range of motion, flexion, extension. If we think there's any possibility that the cervical spine is involved, I'll look at repeated motion. Is that kind of what you look at as well to rule in or rule out maybe some of those special tests? But I find repeated motion to be pretty good to see if it's bringing on their specific complaint of shoulder pain, because sometimes they might have a little neck thing and but they're telling you it's not the same pain I usually feel. But do you look at repeated motion in people?
Well, not too much. I mean, I guess you're talking classically about like McKenzie kind of repeated motion. I don't. I just screen cervical range of motion and I'll do a bunch of special tests, you know.
Sure.
Um, I've heard a lot of physical therapists I really like and trust say they use repeated motion, and it does make sense to me. But then I tend to go back to trying to be a little more evidence based. Like if someone has a cervical radiculopathy, what are the most sensitive and specific tests for cervical radic? And I tend to go with those. I think a dead giveaway is numbness tingling, right? If they're having broad pain, kind of down their shoulder blade type deal, anything down the arm, numbness tingling. Yeah, that's a big one. But they'll probably do an upper limb neural tension test, maybe some Sperling stuff. But largely, I'll ask the question to the patient: do you think your neck is related to your pain in any way? And then I'll just do range of motion testing. Then I might do some special tests, right? And then I'll start doing some special tests for the shoulder, and then we'll kind of see, does it seem more necky or more shouldery, right?
Yeah, totally.
Yeah, funny. Um, yeah, and after we've kind of rolled out those things, I also tend to think about shoulder instability, just because I think that shoulder instability has a slightly different type of treatment than rotator cuff related pain. And by shoulder instability, I mean kind of this frank instability in either, let's say, external rotation, horizontal abduction, so more of an anterior instability, or posterior instability with arm across the body. And I think you pick up a lot of this in the subjective. If people have said they had a dislocation or subluxation or feels unstable, right? That's another giveaway. And I just think that's important because if I do have someone who had, let's say, a dislocation of the shoulder, that's obvious as instability. But if someone does have some sort of anterior instability, I may want to stay away from end ranges of motion a little more so, just to protect that joint. Whereas if I have someone with rotator cuff related pain, I'm probably going to push to end ranges a little bit more so, as long as it's feeling okay, right? But I think the big takeaway is that if someone has like shoulder pain, it's probably going to be treated very similarly across different diagnoses. So if someone has, let's say, infraspinatus, supraspinatus, maybe subscap is a little different, but you're still treating it similarly. If someone has a slap tear, if someone has bicipital tendinopathy, they're all going to have a very similar treatment. So I think the big one is try to figure out if it's some sort of diagnosis that's like completely unrelated from a treatment perspective. And once you get that, I think you're doing pretty well. So
Totally. Yep.
yeah, and then it comes down to diagnosis, right? And I think from rotator cuff perspective, there's so many special tests, right? Are there any good ones you really like to hang your hat on for rotator cuff related pain?
Oh, geez. Yeah. I usually will look at like a cluster of some pain with the like external rotation testing in different positions, see if the muscle contraction is bothering them. And then, it does seem like depending on someone's sensitivity and how flared up they are, like everything hurts, right? So whether it's Hawkins Kennedy test or a near test or, a painful arc, they're kind of getting pain with all of those things. I guess the more positive findings, I feel more confident that we're dealing with some type of rotator cuff related pain. But I usually do like to see pain with a manual muscle test, something like that. That gives me a little more confidence that maybe we're dealing with a specific tendon pain. How about you though? What do you look for there?
Yeah, I think very similar to you, right? There's so many different tests for, shoulder impingement, subacromial pain, rotator cuff tendinopathy, whatever you want to call it, right? The ones I tend to be doing over and over again are usually resisted, external rotation, internal rotation, scaption, full can. If we're not provoking symptoms, I may take them to like 90-90 external rotation, internal rotation. Might do an empty cam test. I also like Hawkins Kennedy. Theoretically, we're compressing some of those cuff tendons a little bit, so I think that's good. I do think that from like a differential diagnosis perspective, so if I'm trying to figure out this person has like a standard rotator cuff related pain, subacromial pain, or they have a large or massive rotator cuff tear, then you're probably looking at, let's say, drop arm signs. So taking someone into 9 degrees of abduction or scaption, can they hold that? Do they get a big shrug? Lag signs, so take someone into external rotation. Are they able to hold into that position? Do the same thing for internal rotation, hand behind the back, lift off. Can they maintain that? Because if they have a large or massive rotator cuff tear, then we're starting to think about, does this person need a surgical consult or not, right? We'll talk about that in future podcast episodes, but at least from a diagnostic perspective, we're trying to figure out what they have and how bad it is, right? So I think the next important thing to discuss after you've gotten that diagnosis, so you think this person has standard rotator cuff related pain, you've ruled out other things, and also you don't think this person needs to go see a surgeon immediately to get a second opinion, or you don't think they have like an acute rotator cuff tear or shoulder dislocation where they need that consult right away, is to modify your lifestyle, right? And when you look through some of the rotator cuff related pain research, oftentimes this is included in the patient education section, right? So they'll try to educate patients on how to modify their lifestyle so they don't continually aggravate the shoulder. And I've gotten this from Mike Reinold. He tells this to patients all the time. So if you're walking around, you have a rock in your shoe and it hurts, you can take some ibuprofen and it'll make your foot feel a little bit better, but you're still walking on that rock, right? Modifying lifestyle and later on, like training in the gym, is going to help to take out that rock so you don't continually irritate the area, right? So basically, we have to figure out what's kind of aggravating the patient. So that could be like putting on a jacket or sleeping positions or potentially some sort of manual labor or putting things into the cabinet, right? Overhead work in general. And one of the big ones I hear a lot from my rotator cuff related pain patients, and it's winter in Boston right now. So fortunately, get a lot of patients that'll slip, slide, hold themselves quickly with their arm when they're catching themselves, and that can really hurt. So these folks will just kind of re-aggravate the shoulder over and over again just because they're having these little mini falls. So I think it's really important that you just talk to patients how to modify these, put the jacket on with the other side of arm, finding sleep positions that feel good. So typically maybe that's on your side, painful side up, pillow basically underneath the shoulder or kind of wrapped around, right? The arms, also sleep on the back sometimes feels a little bit better. Modifying any sort of work activities. Oftentimes this is tough, but seeing if you can like stand on a stool and do things more at shoulder level as opposed to reaching overhead, that type of deal. What are your thoughts there, Kevin? Anything to add from that perspective?
Yeah, totally. I think those are all things that we hear all the time in people with shoulder pain. But I would say that as I've gotten a little further in my career, that's one thing I feel like I'm getting better at that we don't often think about as a new grad PT. A lot of times we're so interested in what we're finding and what we can give to the patient that we don't always do the best job at auditing their lifestyle and what things are really bothering them. Which I think, they're coming to you with a certain set of pain problems and they're really hoping that you can help them with those specific pain problems. So diving into with the patient and getting more information about what specific things really hurt. Maybe some of those things like sleeping is really a difficult one for me because the person only has so much control of the position they're in while they're sleeping. But all the other things, if we can show them something as simple as how to put on their jacket with a little less pain, and other lifestyle things, if there are small modifications, it's almost more of what we can help them modify and what we have to take away early on than giving them specific interventions. So I think doing that audit and educating the person, it means a ton to them. And you can really reduce someone's pain by, like Mike would say, take that rock out of their shoe early on.
Yeah. Anecdotes, right? But I hear that all the time. And I tell that to patients a lot. If you can just stop doing the things that aggravate this, you're going to feel way better. So you can have a really big drop in pain, a lot of buy-in early on, just because we're removing the things that are kind of aggravating the shoulder. So I do think that's really powerful. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free Mini Course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning. Next thing to think about, and this is kind of related to my folks that like to train in the gym, which is, most of my patients, which I'm blessed to have, is you're probably going to have to modify your training a bit, right? And I think this has to be with what actually hurts. And I didn't say this with the modifying lifestyle, but I just think you have to modify things that actually aggravate the area. You don't have to spend a ton of time trying to modify things that don't aggravate the area, right? Sorry about that. So one of the thoughts is like, I have this rotator cuff related pain. I should probably stop everything in the gym where I'm doing stuff overhead. And it's like, do you actually have to do that? Because sometimes overhead stuff feels decent, whereas let's say something like a bench press is what causes most of your symptoms, right? And oftentimes like an overhead press might hurt, but a pull-up feels fine. I'm not going to stop people from doing pull-ups, right? I will say the big offenders for most of my gym goers are usually going to be bench press and overhead press. And it's generally just press variations in general. I'm using the word general a lot, sorry. And also has to do with heavier loads. So when folks go heavy on bench press, when folks go heavy on overhead press, tends to hurt more. And with tendon issues, usually light, slow stuff feels decent. And then as you start to increase the speed, as you start to increase the load, things start hurting more, right? And then from a modification standpoint, I actually want to try to keep these folks exercising as much as possible and try to keep their program as similar as possible as what it's supposed to be, right? So if someone's supposed to be doing heavy sets of 5 in the bench press and that doesn't feel good, and all we have to do is, let's say, reduce the RPE, the rating of perceived exertion, and raise the reps a bit, and they're doing sets of 8 to 10 and they feel really good, then let's keep that. Right? I don't want to tell them to stop bench pressing. Let's keep them benching. Let's keep them working towards their training goals as much as possible. 2 reasons for that. So one, you're going to prevent deconditioning. So one of those big problems with, I would say, the old model for physical therapy is that basically you stop doing everything that hurts, right? And then folks get real deconditioned. And once their pain goes away, they kind of ramp back into training, which is not a bad way of doing it. But I think you get a lot of deconditioning from that standpoint. The other piece is that exercise helps you heal. Like there's a ton of research showing that when you strength train the shoulder or strength train other parts of the body, it actually makes you rehab and get better, right? So like when I take away strength training, I'm potentially decreasing my outcome, and patients are going to hate that. They come to you because they want to bench press. So if you're like, hey, your shoulder hurts from bench pressing, I have a solution. And it starts with bench and ends with press. You're gonna be like, whoa, I can keep bench pressing. I'm like, yeah, man, it's actually going to help you out, right? What are your thoughts on that?
Yeah, totally. I think this is one thing, again, as an insider here, and I see you treat patients all the time, that you really excel at. And I think the message that you've been putting out in regards to this is hopefully increasing the level of care for physical therapists. there are so many patients that will come in with shoulder pain that will say, I know I'm not supposed to lift overhead. I was told by my physician said, I should never lift overhead again. I'm just going to horizontal press for the rest of my life. Um, and, very often that's totally untrue. So one thing Dan will do with his patients is keep them training at the highest level possible. And I've seen you sometimes, take out a sheet of paper and write down all the lifts that someone does and have them rate on a scale of 1 to 10 how hard it is for them or how much pain it's giving them. And, whether you take their word for it there or you go into the gym and try some movements, for those lifts that are giving people over 5 out of 10 and pretty significant replication of symptoms, instead of just totally cutting it out, Dan might go from a bench press to a floor press. And maybe we find that 6 or 7 out of 10 pain is now down to a 3 or 4, right? And it's warming up and they feel a little bit better. And then that person leaves very excited because they can still floor press. They can still do the things they love in the gym. So, I think that's one thing that is really indispensable that as PTs, we should excel at. We should be able to find modifications for these patients. And, it's something that I see you do day in and day out. And I think your patients really appreciate it.
Wow. When I brought Kevin on to this podcast, I didn't realize I would get so many great compliments.
That's right, man. I'm here to feed the fitness pain-free ego.
I'm not going to say I don't disagree with you because this is my thing. So yeah. All right, cool. Nice. And I think the next kind of natural question kind of becomes what's okay to do in the gym and what's not okay, right? And I take a lot of my ideas on this from the pain monitoring model, right? Which essentially means that if your pain is less than a 5 out of 10, and then basically that night, the next day, you retest a certain movement, right? Let's say it's like a push up or something, and your pain is kind of back to baseline, then those movements are probably okay. And if you haven't heard of the pain monitoring model, basically, this has been studied in a variety of different tendons, but Achilles tendon is a big one. Patellar tendon is another big one. But you'll see it all over the place with research. Generally speaking, if you have someone continue, let's say, running and they have Achilles tendon pain, right? And it does hurt when they run, but they're not limping and their pain is minimal. You compare that to another group that doesn't run and they'll just do exercises for the Achilles and they're not allowed to push through pain. What happens in the long term is, generally speaking, they have the same outcomes. They both improve, right? And in some studies in the short term, essentially the group that was allowed to push through some pain gets better faster, right? And the other term you'll hear a lot of in research, particularly in the rotator cuff, is the word tolerable, right? Jack Hickey uses this word a lot in hamstring strain rehab too. So if the movement feels tolerable to the patient, then it's probably okay, right? I just often tell patients that this is an experimental process. We're going to do our best at guessing the movements that are right for you. And then over the course of time, you give us feedback about what ends up kind of feeling good and what doesn't. And sometimes you really have to talk to the patient and try to figure out if they're the type of patient that pushes too hard or the type of patient that doesn't push at all, and you need to give them a little bit more, right? I was talking to a patient that had ACL reconstruction with me a year or two ago, and she's the type of patient that just like blows through pain 100% and just never like listens to her body at all. And sometimes these patients are nice because they're never complaining about their pain, right? But then it's also frustrating because it's like, man, you just gotta just be a little more mindful of this, right? And just like if your body is really giving you the signal that it's hurting a lot, you can't ignore it because it's trying to tell you something, right? Then you have the other end of the spectrum where you have these folks that just like any sort of pain whatsoever, like, whoa, we need to stop. We need to stop doing this. I'm tearing my rotator cuff. I'm severing my spinal cord, right? We hear those things. So you just have to kind of educate those patients, let them know, like, nah, you're safe. It's okay. Not too big a deal. And that's always tough because you're try to give them a little bit of hope and confidence in their body without trivializing the condition. Because if you do that, then you lose a lot of empathy, and then folks just feel upset. So that's just something you have to navigate. Where I think like communication skills become important, and just reading that patient and just trying your best to figure that out. But what are your thoughts on that? Do you have any clinical pearls from that perspective, Kevin?
No, that's great. I think it does take a little confidence in your diagnosis to roll with that 5 out of 10, right? If we're talking about rotator cuff related pain here. So, with that diagnosis, that's totally fine. I think you do want to be pretty good about making sure you rule out like that cuff tear or, and other pain problems. Like if someone's dealing with a bone stress injury or, joint effusion, we're a little more cautious with that 5 out of 10. But, if we're following that pain monitoring model, was that Silbernagel that came up with that?
She actually wasn't. She was one of the first. So that article what she did was like 2006, 2007, and she mentioned the pain monitoring model in that, and it was from
Mm,
another study. And I always feel bad because I forget the author, and I
yeah.
I really am just like using their model and like pretending like I came up with it, and I didn't, and I don't remember the original author, so it's
Yeah,
bad.
yeah. We use it at Champion all the time, and we talk to the students about it, and we talk to our patients about it. So I think once you're confident in your diagnoses, and even if initially you're not super confident in it, and then you find over the course of a week or so, the person is at that maybe threshold of 4 or 5 out of 10, but then they find that that night, the next day, they're kind of back to their baseline. Then you kind of know you're trending in the right direction, and they're happy that they can keep training. One other thing, quick, that I know you talk about a lot and that we try to talk about with our patients is, like you said, you could either work through no pain and this might get better over time, or you can keep doing the things you love that are good for your health. And, maybe your pain will get better over time, but if you completely stop training, your other health markers might plummet, right? You might start gaining weight, your mental health might not be as good. So it's always important to weigh the pros and cons of working through some pain. And I think most of the people that come to see us, we're in a setting where people are extremely active and they'll do almost anything to work out. And a little pain, as long as they know it's not making them substantially worse, they're totally cool with it.
Yeah, I agree 100%, right? We want to keep people exercise as much as humanly possible. My personal opinion, but again, you don't have to, right? It comes down to your style as a physical therapist, but that's just what I prefer. All right, boom. Next step is to apply a progressive strength program. And this is a little bit of a pet peeve to me. And I think it's just a kind of a cultural thing from the strength training world, right? So I guess two stories. Just the other day, I put out a Instagram short, which never has great context. And they just blast it out to a million people, and YouTube is like a cesspool sometimes for people with comments. They're just like mean or they're just mad about whatever, right? And it's funny because one person responded with something like, "Oh, number one test for shoulder impingement is pain with pressing overhead. If you want to wreck your shoulders, you should do overhead pressing variations, right?" With shoulder impingement. Like, never hire this trainer,
Uh,
basically, to me. And
yeah.
like, my first thought was like, do I even respond to this? Like, I don't think there's going to be anything good that comes from this. You know what I mean?
It's so tempting. You got to
Yeah. But
respond.
yeah, well, there's just like, and I don't think coaches should blow through pain in the gym with their patients, right? But I think the big thing is that folks are so afraid to load anything that's painful, right? And I think one of the pieces of information that you'll hear a lot on like Reddit forums, YouTube, you see this from a lot of trainers, is that if it hurts the press, you should stop pressing and just do lots of rowing, right? Do the opposite because that's going to balance your shoulder out, right? And I think a lot of the shoulder balance came from the baseball world, right? We work with a lot of baseball players. With baseball, it's interesting because when you throw a ball, you have to accelerate it with a certain set of muscles, and then you have to decelerate your arm afterwards with the opposing muscles, right? So it's like if you don't have really strong opposing muscles, then you're basically overpowering, right, the backside of the shoulder, which potentially leads to problems. And then that's one of the reasons why folks get limited internal rotation, they get weak in the, you know, external rotator, so on and so forth. If you think about weight training, you accelerate the bar with one set of muscles and you decelerate it with the same exact set of muscles, right? Right. It's not like the back of the shoulder kicks in during the lowering portion of the lift. So I think it's just like a misunderstanding of the actual biomechanics of it, right? And the other piece I will say is that if you have Achilles tendon pain, right? What's the number one treatment for Achilles tendon pain? Is it tib
Calf raise.
anterior raises? What do you
Yeah.
do?
Calf raise. Load it.
Yeah, you load it, right? So it doesn't make any sense to me that when you have shoulder pain in the gym, you like stop pressing and you just row. It's like, all
Such a
right,
good
we're
point.
gonna not target the tissue that's irritated. Um, So I take the exact opposite stance, right? Basically, I want to continue targeting the irritated tissue with exercise. And I think that actually ends up being a really positive thing for your patients from a psychological perspective. Because you're like, hey, when you feel that pain, it means the medicine is going in the right area because the exercise is the medicine and you're actually doing the right thing by exercising that tissue. So it kind of flips their mental a little bit. And again, you have to just read the patient. If you're one of those patients that blows through pain, that's the last thing you want to hear. So they're like, great, I'm crushing it. It's like, no, you're crushing your rotator cuff. You need to back off a little bit, right? But generally, I like to target the painful tissue. So you aren't during your clinical examination. If it hurts with, let's say, external rotation or scaption or abduction, then you probably want to start with exercise to kind of do that, right? Any thoughts? Anything to add from that perspective?
No, that's really interesting. I guess I never thought of it in that lens of the weightlifting, right? It's you're using the same set of muscles with the whole lift. So you got to start loading it. And our mutual friend Chris Johnson has a saying, load the tissue with the issue. And I think that's great. I try to keep that in my mind all the time. So yeah, I think that's awesome. So would you say if you were working with someone, say anterior shoulder pain, um, bench pressing, and we were finding that all press variations initially were very flared up, say this was an acute rotator cuff related pain, you cut that out temporarily, and then as soon as they feel like they're back at that threshold where they're not flared up for days after pressing, you're adding it back in. Do you load up rows a little more early on um, if the person is a little too reactive with pressing still? Or are you doing that maybe more rows, but you're still giving them exercises for their pec or anterior deltoid or something like that?
Yeah, both. And I think it depends on the patient's preference. But let's say they have an upper body training program that's twice a week, and it's got about an equal amount of pressing as rowing exercises, which a lot of programs have. Basically, I'll just modify the presses and continue all the rows. If rowing feels fine, I mean, there's a few folks that rowing hurts as bad or worse sometimes than pressing. If that's the case, you're gonna have to modify your rows a little bit.
Yeah.
But largely, I try to keep in as much of both as possible. And if their pain is so bad with pressing, then I have no modifications that work well, which doesn't often happen. Like I'll even just like throw things in because I find that if you even have a really, really irritated shoulder, we could probably throw some BFR cuffs on you and do some like really light dumbbell press. That's usually
Mm,
tolerated pretty dang good, even if you have a really irritated shoulder. Or maybe you can even do like BFR with some of the rotator cuff exercise or something along those lines. It's usually something you can do to maintain some of the pressing as much as possible. But if I have to pull out some of the pressing, I might replace it with some rowing. And I think from a psychological standpoint, that feels pretty good to the patient because they can actually do a little bit more. So maybe they're overemphasizing their pulling muscles now because it's something they still can do. It's like a nice training effect there. Maybe they're focusing more on building their upper back or something along those lines, which is nice from a psychological standpoint and a training perspective too, right? So
totally. Yeah. So maybe keep training volume, overall training volume the same, and then whatever movements fit for them at that point in time.
yeah, I think a lot from the mental standpoint. Like people come to me because they want to continue training. So if I can keep that training window like the same exact challenge and length of time as possible and work towards the same goals, that's a big win for me, right? So
Totally. Yeah.
yeah. And from there, you start with the basics. So I always tell patients it's super boring to do scaption, external rotation, so on and so forth. But I really think that's kind of like the best medicine. I almost always start there for folks that are highly irritable. For folks that aren't highly irritable, you can just start with higher level stuff, right? There's no rule saying you have to start in phase one necessarily, but those are the ones I tend to start with early on. And you can also start with isometrics if someone's not doing well with isotonics, right? So you got a lot of options there. And in terms of progressions over the course of time, I think two things. So for one, you can increase the loads, right? The speeds of movement or just challenge of the exercise. So choose harder exercises. But I think the other thing that becomes really important is now specificity. It's like, what is your athlete or person in the gym, whatever, trying to get back to, right? If that's, let's say, heavier bench press, because that's what hurt before, then you probably want to choose exercises to help facilitate that, right? So, using bench press by itself and just slowly increasing the load over the course of time, or using variations that are maybe a little nicer on the shoulder. So, maybe like a Swiss bar press, dumbbell press, something like a spoto press or a floor press where you're cutting the range of motion, adding load over the course of time, just trying to just make it super specific to whatever the athlete's trying to get back to.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up, it's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for a 1-week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
No, awesome. Yeah, I think you nailed that. I think finding the most they can tolerate, keep them training, it will keep them happy, right? So that's great.
I included some honorable mentions because as physical therapists, we love exercise, but we do other things too, right? And maybe it's not so popular on social media right now, but I do mess around a little with manual therapies, right? We do some laser, some shockwave, right? Some modalities. I did a little lit review just to see the effect of some of these additional things, right? Manual therapy being one of those. And it's really interesting, right? And it's funny. I was looking at this stuff just last night. But you'll find these big kind of systematic reviews, meta-analysis that show kind of no difference between manual therapy plus exercise versus exercise alone. So a big study in sports health. I'm going to mess this guy's name up. It looks like a Greek name, Paraskevopoulos, Sports Health 2023. So pretty recent article. No difference between groups in terms of pain and function. This was a longer term outcome, right? Peters et al. In 2020 gave a strong recommendation regarding the inclusion of manual therapy in the initial treatment phases. And I looked through that article a little bit, and largely using manual therapies were helpful in the short term. So either immediately after exercise or within the first 3 weeks or so, right? And it's funny because I was looking last night and there's just a study published in JOSPT, and I'm going to do a video about this, but I was looking at manual therapy plus exercise versus exercise alone, and actually showed a short-term and long-term benefit of the manual therapy. And it was a randomized controlled trial just published in January of 2024. So what I will say is that this research is super confusing, right? And who knows what you're supposed to do. What I will say is that I personally do use manual therapies for a lot of my patients, not all of them, but I will use it with my patients with shoulder impingement, shoulder, subacromial pain, whatever you want to call it. And it really depends on the patient. I don't give it to all of them, but some of them I think they can really benefit. And at least the techniques they use in these studies, largely you'll see joint mobilizations, posterior, inferior, some anterior, some long axis distraction. I'll do a video on these at some point so it makes a little more sense. They'll do some specific soft tissue stuff, so scalings, SCM. They'll work on the pecs. They'll work on the posterior cuff, that type of thing. You also see some mobilizations for the spine, so cervical spine, CT junction, thoracic spine, mobilizations and manipulations. So, kind of all over the place. What are your thoughts, Kevin? You use manual therapy, right?
Yeah. My thoughts here are, it's very confusing, the manual therapy research, right? I think, like you just noted, that new paper that came out, that randomized controlled trial, I did see that. And like you said, it did show some improvement. I can't remember all the details right now, but, that was in contrast to some of the meta-analyses that have showed that, it's not as effective, right? So the way I try to handle it is, on a patient by patient basis, right? So some patients come and see us and they just want a program that they can work on their own. Maybe they check in every several weeks or every month and we update their program. Obviously, that person is not getting any manual therapy. Some other people, the way I try to go about it and the way I talk to the students and try to have them go about it is if someone's coming in to see me, I want to check some baseline things every time they come in. So they come in, let's lift overhead, let's see how your mobility looks, let's see if there's any pain. So you have a pre-test and then you do whatever manual therapy technique you're best at. So I think that's one thing is for a lot of these, the benefits are, or the technique can be pretty non-specific, right? So maybe we're doing soft tissue. Some patients love dry needling. Other patients like tool work. Maybe we do whatever modality we want to work on, and then we recheck that baseline. And I think that's huge because if the person is not showing any change and they don't really know why you're doing the manual therapy in the first place, it's totally not worth it. They might just think like, why am I coming here, wasting my time in person? We didn't check anything. I don't know if it's helping. It feels good. But other times I think patients, you can see an actual change, right? Whether that's in range of motion. I'll have, like you said, we treat a lot of baseball players to champion. So maybe they were throwing, their shoulder feels pretty crappy. They come in, we do some soft tissue, they throw again, and they feel amazing, right? So whether that's what a mechanistic thing that's happening or, there's so many things that go into it. Psychological reasons people feel better after manual therapy, that gets very confusing. But if you have a pre-test, an intervention, and a post-test, and the person is feeling better, then I will continue to use manual therapy. I'll just be very cautious about how I explain what I'm doing and why it's working. I try to be as honest with the patient as I can and, not tell them that it's breaking up scar tissue or anything crazy. I just try to tell them, well, we looked at this one thing, we did this and you're feeling better. So, there could be a bunch of mechanisms why, but let's roll with it for now. And I'll try to always show them a way they can replicate that on their own if that's possible.
Yeah, good point, right? They can use a foam roller, they can use a ball, they can kind of work on that stuff on their own, right? One thing I agree with you completely. One of the things that, like, as an early career professional, a little bit, newer as a clinician, I was kind of a bit of an evidence-based Nazi, like just very extreme. And I think what ends up happening, and if that is your style, and we're lucky because we're out of network providers, so it's not like we have to, argue with insurance companies about what we do. I ask a lot of questions about what the patient wants, right? And I think a lot of what I do is dictated by their needs and desires. And as long as they know that, hey, you're probably going to get better long term with manual therapy, the same rate as just giving a couple exercises, that's fine, right? I think the other part is that some folks kill, right? I had a patient that came in the other day and she has tennis elbow and it kills. She feels god awful. And she went to her doctor and doctor's like, it'll probably go away in time. Don't worry about it, right? And she hated that. And she just felt like completely invalidated by that. And she came in to me and I was like, well, doc's right. In months to, sometimes up to 9 months or so, some of these studies will show for tennis elbow, it'll probably go away without doing much anything for the average person. But like if we treat it, we know it gets better faster. And I did some manual therapies, gave her some exercises, and I did Shockwave on her elbow. Next day she texted me, she's like, oh my God, I feel so much better, right? And it's like, that's what she wanted. You know what I mean? And like, I'm not telling her, because she's like, oh, should I come in 3 days a week for Shockwave? I was like, no, I don't think you need that. Like, you don't need to do that. Would I make more money if I said that and made her believe that? Yeah, but I don't do that. I'm not trying to, you know what I mean? That's not what we do as physical therapists. But the other part is like, she got a lot of benefit from that. And I'm not going to hold that from her. And that's completely what she wanted. So I think that was a big win, right? Yeah.
Oh, that's a great point. Yep.
And this kind of segues to the next one is Shockwave. So we got a extracorporeal Shockwave machine at Champion. We're pretty dang lucky, man. We got some cool toys, right?
Got everything, man. I know we're so spoiled.
I know. I wanted this for a while because I was reading all these studies about Shockwave being helpful for these varied different types of issues, right? Like bone stress injuries, like Morton's neuroma, strain injuries, tendinopathies all over the dang place. So, I've been trying on a lot of stuff recently. And, it's funny because it seems to be pretty beneficial in a lot of areas. One of which, not so much, is for rotator cuff related pain, right? And I was actually talking to one of my patients who's a physiatrist who does like PRP injections and prescribes a lot of Shockwave. And I was like, why do you think this is? A lot of other tendons do well. What's the deal with, the shoulder? And one of his responses I thought was pretty interesting is that I think we have a tough time with differential diagnosis in the shoulder. We mentioned it previously because if you have like anterior shoulder pain, it could be your rotator cuff, could be your biceps tendon, subscap, right? Latin teres is in that area, pec minor, pec major. There's so much stuff that creates anterior shoulder pain. And we're just going to like blanket try to hit that with, shockwave therapy. Are we actually hitting the right structure? And I think you see the same thing with PRP in the shoulder too. It's like kind of hit or miss in terms of how it works. We know there's so much asymptomatic pathology. It's kind of like we might not be hitting the right area. Whereas the other parts of the body, we can be a little bit more certain, like, yeah, we are in the right area, right? Before I get your opinion on this, what I will say is that there's a bunch of studies that actually show that calcific tendinopathy in the shoulder does pretty well with Shockwave. So if you have a patient that's not making progress, they go back and get some imaging and it looks like calcific tendinopathy, then they may actually do pretty well with other types of procedures like Shockwave. So I think it's potentially still worthwhile maybe in the shoulder to try. The research seems to be conclusive for rotator cuff related pain from the studies I read. There's several of them. It doesn't work so well, but if they're dealing with calcific tendinopathy, may be beneficial. What are your thoughts? Any success with Shockwave?
Yeah, I would say I haven't been using it for our patients with rotator cuff related pain. I think what you said, I kind of see with my patients, like the pain might be diffuse enough that it's not like an Achilles tendon where it hurts right here and it's a very specific spot. And again, I think if we have access to this thing, so if we're trying a bunch of things and their pain problem's not improving, we're lucky enough that we can go out to the gym. We don't bill for Shockwave specifically, right? They're there for PT for whatever given amount of time. I might try it. I haven't tried it with rotator cuff related pain, but try it and see if they notice any improvement. It would probably be using the same type of strategy I use with manual therapy. So I'd want to get some baseline of the pain problem, do the Shockwave and retest and see if it's improving their pain problem. Unless something were to come out and saying it was changing the tendon and it was making the tendon, quote, healthier tendon and it was accelerating recovery, I would totally use it then. But for strictly for pain problem, I haven't been using it for that.
Okay, so you learn a bunch about non-op rehab. Sometimes when a patient comes in with a rotator cuff related pain, or more specifically, a rotator cuff tear, your first course of action isn't non-op rehab, but actually might be surgery. And if you have a patient who trials non-op rehab, and after a period of time, they're not doing well, the next step might be surgery. So in today's video, we discuss surgery versus physical therapy for rotator cuff tears to figure out what's going to be best for your patients. And for those patients that maybe fail conservative rehab or physical therapy, what are those next steps? This one's a banger, and I hope you enjoy. And the study we're looking at today is called Conservative versus Surgical Management for Patients with Rotator Cuff Tears, a systematic review and meta-analysis by Longo et al. In 2021. Did you read this, Kevin?
Ooh, I did read this. Yes, to prepare for
good
the
thing, 'cause
podcast.
I did not. Just kidding, I read it.
Let's just wing it. Yep.
Let's wing it. All right, we'll get into this. So I think first we're going to open this up with a little bit of a discussion because I think that, as a new physical therapist, I didn't have this information, right? And I talk about it a lot with students at Champion. I know you do as well. It's a little confusing. And right now we have a very hopeful message going on here in terms of like, there's a lot of asymptomatic pathology and that's fine. It's all normal, right? But there's some people who have symptomatic pathology and rotator cuff tears are a thing. And sometimes they get bad and sometimes you need surgery. So it's kind of like, all right, everyone has a rotator cuff tear. Then the patient that comes in has a rotator cuff tear. That shouldn't matter, right? It's normal. This person. Mm-hmm. And I think that two things. For one, it invalidates the patient's like feelings. Like, hey man, my shoulder hurts. Oh, who cares? Everyone has a rotator cuff tear, right? So you do end up kind of annoying patients, I think, from that perspective. The other thing is that it's actually relatively rare to have a full thickness rotator cuff tear over the course of your life. Having a partial thickness rotator cuff tear is actually very, very common, right? And largely, folks are not getting rotator cuff tears until they're in their 40s and 50s, unless you're an athlete, right? And then you're getting at like 8 years old. There's like partial thickness rotator cuff tears and throwers, right? Just absolutely crazy. But if you're getting rotator cuff tearing in your 20s, that's not common. If you're 80 and you don't have a rotator cuff tear, obviously that's uncommon, right? I think it's like around 80% of folks will have rotator cuff tear before they die. But the rates of the full thicknesses are actually going to be a lot less, right? So there's this idea that if you have a partial thickness rotator cuff tear, then yeah, you want to go just do conservative physical therapy, whatever it is. Don't jump into surgery right away. Although in some folks, maybe they do end up getting surgery for partials, but it's a little bit more rare. But once you get into the world of full thickness rotator cuff tears, we start thinking, maybe we should start thinking about getting this thing repaired. And there's a variety of reasons for this, right? One of the things I think is important to keep in mind as a clinician is a difference between a full thickness and a partial thickness, right? And I think this really helps to educate your patients about this. I'm going to try to basically make a rotator cuff onto my hand here. So let's say it's my glenoid, right? So I got my humerus right here, comes on my glenoid, and the rotator cuff tendon comes across and attaches right through here. So essentially, if I have a partial thickness rotator cuff tear, that means that I have a portion of my tendon that is torn, right? But it's not torn all the way through. And once I get a full thickness rotator cuff tear, I have a portion of that tendon starts to tear off. So maybe that starts with like 25% and then 50% and then 75%. And if it's like completely torn, then it's all the way off, right? But you can have a full thickness cuff tear and it's still attached. And what that means is that it's still freaking strong, right? Especially if like the large majority of it's still attached on there. Once it completely pulls off, then it becomes an issue, right? And the other part is if it starts to retract, so it gets further and further away from that glenoid, that's a worse and worse tear. And the problem is that the larger the cuff tear is, the faster it will progress over the course of time. Generally, the more disability and pain someone has, so at least in the rotator cuff tear, the worse the pain is, right, on imaging, or excuse me, the worse the tear is on imaging, usually the worse your pain is from a patient perspective. And that's kind of the opposite of what you may hear in the social media landscape. Just largely that cuff tears are asymptomatic, all of them. It's not really true. The larger the cuff tear is, the increased likelihood that thing hurts, right? So that's a problem. And if you have a fully retracted tear, if it's retracted a lot and it's been retracted for a while, from a surgical standpoint, either A, you can't repair it, gets cemented back here and the surgeon can't pull it back, or it takes a very skilled surgeon in order to do that. But also the re-tear rates get worse and worse and worse, the worse the cuff tear is. The other thing we know is that the majority of cuff tears progress over the course of time. So then it becomes this idea of like, do I get my rotator cuff repaired in order to improve my long-term outcome? How long should I wait, right? Do I wait at all? Should I try conservative treatment? And luckily, we have a few studies that help kind of guide our reasoning, right? Before I get into that, I just spoke a lot, Kevin. What are your thoughts on everything here so far?
Yeah, this is probably something I was guilty of when I first started treating and, pretty active following people on social media, is really, being in that camp of rotator cuff tears or like gray hair. Over time, we're all going to get them and they're probably not something we need to worry about. But, it is a little more nuanced than that. And that's something I've been lucky to learn from working with you guys at Champion. This totally is like it depends situation, and you're going to get into all that right in this podcast. But there are a lot of factors that are going to determine if you should get it repaired. What was the nature of the mechanism of injury, right? That's going to play a role. How old's the person? I think that's going to play a role. What size is the tear? That's going to play a role as well. So these are things that we need good answers for so we can make the best clinical decisions with our patients. Because, I think the last thing I'd want, something I'd be fearful of as a clinician, is brushing it off and telling the person that, this is normal. You're in your 50s. You have a rotator cuff tear. Let's just try PT for a while and don't bother consulting a surgeon. And then months and months or years down the road, their shoulder has progressively worsened. And I tried to do what I thought was best for the person, but because I didn't have the best information from the Fitness Pain Free podcast,
Whoa.
I didn't make the right clinical decision, and that person's long-term shoulder health is suffering. So there's a lot to it. And I think one thing that you'll probably talk about is, establishing a good relationship with a local surgeon. And, sometimes I think what I'll do is I'll have these patients just consult a surgeon and get some baseline information. And, the surgeon will say, hey, you are 40 years old and you fell on ice. And I think this is something we no brainer need to go ahead and repair. Right. So, you don't have to make the decision totally by yourself, but, yeah, there's a lot to it. So I think the kind of going down that avenue of saying it's normal, it's common, but I don't know if it's normal. And we want to be careful about, like you said, just dismissing the patient's fear, that they have this issue. And sometimes, I think it's okay to reassure and start exercising, but sometimes we want to make sure we have all the information so we're making the best choice possible for the patient.
Yeah, I totally agree. You said a lot there. Hopefully we get to all those things there, right? But, one, importance of a good surgeon, and you have to be cautious too, because some surgeons, they like to cut quick, right? Don't always give the patient the right information. So yeah, having a good surgeon you trust is important. And the other thing is, like, you don't have to make this decision alone, right? You can talk to the surgeon, talk to the patient, give them the research, right? So if you have this information, you can tell the patient and they can make an informed decision, which at the end of the day, that's what we're trying to do, right? I'm not trying to tell patients that they need to do this, they need to do that. I mean, they're allowed to make their own decisions. I feel like sometimes, with physical therapists, as well as surgeons, you go to them and they're like, this is the way. You know what I mean? It's like, well, you have any choices here? Like, what? It's like, am I
Totally,
allowed to make
yeah.
a decision here?
Right.
So,
It's a risk reward ratio, right? The patient, if they have all the information, it's their decision, but it's our job to provide them that information.
yeah, for sure. And I think I hit on some of these, right? But from a surgical outcome perspective, what I will say is that if you have a small to moderate size, full thickness cuff tear, the outcomes after surgery are pretty good. A lot of folks are just so fearful of surgery, and I get it. Like, no one wants to get a surgery; it's a huge pain in the butt. But these tend to do well. It's kind of like, well, if you get this surgery, chances are you'll do well. And I think patients are always like, oh, my Uncle Larry, he's had a rotator cuff repair. Now he can't even use his arm. His arm is dead. They killed it during the surgery. I'll never get surgery. And it's like, well, freaking Uncle Larry is like the worst patient of all time, right? Like, you can't like base your expectations on that. So I do think it's important just let patients know too that, like, surgeons aren't evil. And then oftentimes it can be a really good option for you, right? Um, and then, like I said before, larger and massive rotator cuff tears don't have as good as an outcome. And what I mean by that, so generally a little bit more pain, a little bit less function, and they have a higher re-tear rate. And it really depends on the size of the tear, but re-tear rates, you've never heard this before. And this is funny, like, one of the most popular videos I've ever made on YouTube is, when do rotator cuff tears fail after surgical repair? And I meant it to be an educational thing, but it's like basically patients go on YouTube and they're freaked out after their surgery and they go on there and they listen to that. That'd probably freak them out more, right?
Right.
But there's a higher re-tear rate the worse the tear is, right? Up 94% of some studies with these large, massive tears re-tear. And what's kind of unfair is that when a cuff tear re-tears, it doesn't always fully tear to the same degree that it was prior to surgery. Sometimes it's a partial tear. So that's not really fair, right? And the other piece that's really cool is that even if you had a re-tear, your outcome's usually pretty good, meaning your pain goes down and your function improves anyway, which is kind of crazy, right? But I think from a long-term health perspective, we really want that thing to reattach, because I don't want that thing to continue progressing over the course of time. If it re-tears after surgery, it's going to keep going most likely, right? So the question becomes, can we rehab these conservatively? And after that, should we? And I think the answer to that is a big old yup. And like, from rotator cuff tendinopathy, so let's say you have no tear, you just have some tendinosis, tendinopathy, up to partials, to full thickness, to massive, to fully retracted, we know that physical therapy works for all of those tears, right? But I think, like we were just talking about, is this the best long-term outcome for our patients, right? 5, 10, 15 years down the line, should we have had a rotator cuff repair? So we look to studies like this one and try to figure that out, right? So the study was called Conservative versus Surgery for Large Full Thickness Rotator Cuff Tears. It actually wasn't called that, but that was like the study name in a nutshell. And basically, it was a meta-analysis, had six different articles combined together of patients. And he looked at outcomes. So basically, the only outcome that was consistent across all those studies was a constant and Murley score, right? You use that with your patients?
Oh yeah, that's the only one
Constant
I
and Murley
use.
score.
Yep.
I've never used that one personally, but yeah, that's the one that was consistent across all those studies.
Yeah, no,
And the
I
other
actually
thing that
never.
was, what's
Oh,
that?
sorry. I was gonna say I never even heard of it until we did this paper, right? But looks like it measures like pain and function in a bunch of different scenarios.
Yeah, I think it seems like a pretty decent outcome measure, right? Um, for the average person. And basically, they're looking at the constant Murray score as well as VAS, so how much pain you have. And the outcomes were at the 1 year and 2 year follow up. And they also looked at re-tear rates. So how many of these were re-tearing over the course of 1 or 2 years, right? And drum roll, please, Kevin. What were the results?
Boom.
Boom. So at the 1 and 2 year follow up, there's no difference between groups in the constant and Murley score. What do you think of that, Kevin?
Fascinating. Yeah.
Fascinating.
Yep. I mean, I think it goes into, a lot of the stuff you were talking about where so much of it is dependent on a specific patient, right? And these big studies that group them all together, sometimes it's hard to figure out if your specific patient is going to be like the average person in this group. But I think it gives us some confidence that, if we do have someone who we're going to try to rehab conservatively, if time isn't an issue and this isn't something that was acutely just happened and they're going to go do surgery, we could try physical therapy. And if they're responding well, maybe we can have confidence that we made the right decision in conservative management. And if they're not responding well, maybe they could still go get surgery, and they might end up doing better then. And so if it's the patient's preference to avoid surgery, we can tell them that, your outcome might be the same, so this might be a good decision for you. Let's try it and see where you're at in a couple months.
Yeah, I think that's entirely reasonable, right? And we'll get into like how fast rotator cuff tears progress and whether or not we can even predict if they are progressing over the course of time. But that's a really hopeful thing to hear, right? Basically, like at the 1 and 2 year mark, the outcome from an outcome measure perspective, the function is the same, right? Pretty dang cool if you get surgery versus just treated conservatively. What I will say is that, and I don't know, maybe you saw this, but I couldn't figure out whether those patients actually got physical therapy, right, in those groups. And I think I would probably have to go back and look at the original papers, which I didn't. But would those outcomes be a little bit better if they actually perform physical therapy, right? Because
They
from a
did.
pain, go ahead.
Yeah, they did, but they didn't include what exercises they were performing. They gave general recommendations for like scapular strengthening and rotator cuff strengthening, but there were no details. And I even went into some of the actual studies that they included in this, and similarly, those studies didn't have specific exercise programs. So that is hard to say, exactly what they were doing. And I think, like a lot of the studies, when they try to standardize the treatment, we don't see what a lot of us that are very into strength and conditioning would consider a good strength and conditioning program. But in this specific study, there weren't the details given for that.
Okay, yeah, that's good to know as well. Because pain at the 1 year follow up was actually in favor of the surgical group, right? And I always think looking at these numbers is important just because it's statistically significant, but the difference is not huge, right? So in the surgical group, the average pain was 1.4 on like a 0 to 10 scale. And in the non surgical group, it was 2.4, right? There's literally like 1 point higher, which is significant, but how significant, right? So it was a little bit better for the surgical group. And at the 2 year follow up, they said they couldn't report on pain. I don't remember exactly why in the study. I just remember taking some notes, and they weren't able to compare pain at the 2 year mark. So still a bit of a question mark. The next thing they reported on was re-tears. And at the 1 year mark, 35% of patients had a re-tear, right? And the information I really wanted to know they didn't provide was what was the tear progression for the non-surgical group? Because that's really what we want to know, right? Are these things tearing over the course of time? Does getting the surgery reduce the likelihood that we have tear progression? Because if 35% of people are re-tearing, right, but only 35% of patients will actually progress, then like, are we doing anything by having a surgery? Right? It'd be really nice to know what's kind of going on in both of these groups, but unfortunately, we didn't get that. However, Kevin, boom, I have another study. It's funny how often I talk about this study, the Moose Mayer study. So, what the heck happens at 5 years, 10 years, 15 years? Because that's really the reason why I would consider getting a rotator cuff repair. Just because at the 1 year mark, seems like the outcome's the same. It doesn't tell me much. What about 5, 10, 15 years? That would potentially make sense. So Moose Mayer et al., 2019. I'm hoping they're going to follow up again this year at the 15-year follow-up to see what's going on. This study was called, at a 10-year follow-up, 10 repair is superior to physiotherapy in the treatment of small and medium-sized rotator cuff tears. These were full-thickness cuff tears. This study was included in the original study we were talking about in that meta-analysis. Basically, they're looking at longer-term follow-up, 10 years out. And what they found was the surgical group was superior to the non-surgical group, both with pain, right, and the outcome measures that they were looking at. So the constant Murley was one of the ones they're using that in that group. They also said the surgical group outcomes remained stable. So essentially, over the course of time, if you had your rotator cuff repaired, then things stayed about the same, right? You had this continued success. And then in the conservative group, the outcomes continued to decline. So over the course of time, pain got worse, as well as outcome measures got worse. And a decent chunk of patients went on to get surgery. So 27% of patients went on to have surgery over the course of 10 years, right? So to your earlier point, kind of seems like patients are having pain. If they want to go on to get surgery, great, right? That's fine, they can. But I think the issue there is that, will their outcome be as good because they waited longer, as opposed to just getting it from the outset, like the first group seemed to do pretty well. And the other thing is, like, how many years of pain do you want to be in before you get it repaired? I can't tell you how many like post-op hip replacements I've talked to. They're like, can't believe I waited so long to get this surgery, right? What are your thoughts on this study? I think it's pretty interesting.
Yeah, I think it's very interesting. And that last point makes me just wonder if the conservative group there was progressing their tear over time in a way that was functionally meaningful. One thing I didn't know until you just said it a few slides ago was that they don't always specify how they're determining a re-tear, right? So maybe it was a large tear and then they're re-tearing only a very tiny bit, but it's showing up on MRI, and functionally it's not making any change for the patient, right? So it maybe, makes me think that managing this conservatively, it could go well, but it also could progress to a worse tear for pain and function versus the surgery. When we say that, 16 to 94% re-tear, well, maybe in the long term, it's not enough to really make their pain and function worse, right? So that would make me less quick to say, you don't need surgery. Surgery doesn't matter. You're going to be fine anyway. Because if we're really looking long term, like you said, is the reason why some people will decide to get a rotator cuff repair, they might do better. So I'm looking forward, like you said, if they come out with a 15-year follow-up, and this is so hard to do, and good for Moose Mayer and that group of researchers for doing that. And that's an amazing name.
I find the Moose Mayer. He's my man.
It's so good.
It might be a
So,
woman. I'm not even sure. I'm not sure what the first name is. Let's go back and look.
yeah, let's see.
Sorry if I messed that up.
Should get that right.
Stefan.
Yeah.
All right. It's a man, I think.
Yeah. I mean, it's a great paper. So, the more long-term data we have, like you said, it's all about just having the right information to share with our patients so they can make the best decision possible for them. For sure. Good paper.
Yeah. One thing I should have mentioned earlier is that in these papers where the re-tears occur, but they still have reduced pain and improved function, they'll look at isometric strength too. And the re-tears actually do tend to be a little bit weaker, right? So one thing to keep in mind is that a lot of these studies are in sedentary folks. The average person is sedentary. You're not looking at volleyball players. You're not looking at weightlifters, right? So would you have the same outcome? Would the patient be as pleased with their progress over the course of time if they had a re-tear, if they're trying to get back to CrossFit, right? Which the average person isn't trying to, but a lot of folks I work with, they are. So they may want to get the surgical repair and hope that it actually does take more so than someone else, right? Something to think about. Here's another study. It's basically looking at how fast do rotator cuff tears actually progress. The study is called Symptomatic Rotator Cuff Tear Progression. Conservatively treated full and partial thickness tears continue to progress. This was from Franson et al. In 2022. And their clinical question was, how fast do rotator cuff tears progress? Do they actually progress? And the answer is yes. And we already talked about this, but it gives us a little bit of information about how fast these things do tend to progress if we are going to plan, let's say, for a future surgery, right? So if they looked at all of the rotator cuff tears, both partial and thickness, 61% of rotator cuff tears progressed at the 3.2 year mark. And this was an average of 3.2 years. I think it was plus or minus 2 years, right? So a little over half of these patients will have a progression of their rotator cuff tear at around 3 years, right? Some other stats, 74% of full thickness rotator cuff tears progressed, right? Only 42% of partial thickness rotator cuff tears progressed. And 29% of these went from partial to full, right? So essentially at the 3 year mark, a little over half of these are going to progress, and you're more likely to have a full thickness rotator cuff tear progress faster, which we talked about before, right? The other question that I wish we had more information to answer was, what correlates with cuff progression? New onset of pain, right? Is there a specific thing that we find in imaging that's going to show that this thing is more likely to progress? We have a little bit of information. So the first one you just talked about was a full thickness rotator cuff tear. That's going to increase the likelihood of cuff progression, cuff tear progression. The other thing was subscapularis involvement. And I think the reason for this is because if you have a massive rotator cuff tear, you're going to have multiple tendons involved. So supra, infra, and subscap. So if that subscap is involved, it's probably a sign that you have a massive cuff tear or more cuff tearing, which makes sense to me. I don't know if that's actually true, but at least in this study, they showed the subscap was involved. Also, tear retraction and width. So if you have retraction, worse cuff tear, obviously. And if it's more retracted or there's more width from the bone to where the tendon has been torn to, more likely to progress. And then disruption of the anterior rotator cuff cable, which is kind of like the anchor point, ligamentous anchor point of the supraspinatus tendon on the humeral side. So if you have these things going on with imaging, you're more likely to progress and probably progress faster, right? What do you think, man? When you hear these things, how does it make you feel on the inside?
Oof, a lot of emotions, I would say. Yeah, that's interesting, right? And it's challenging to think about how to work with that with a patient in mind, right? So you're working with a patient, they have an MRI, they come in, they have a partial thickness rotator cuff tear. If the subscap's involved, maybe you're trying to educate them that this might be one that progresses a little faster, and maybe this is something that's good to get operated on. I guess what I would try to do too, where you mentioned that a lot of times these re-tears or progression of tears might have clinical findings like increased pain or decreased strength. We don't always know, right? But if we're tracking them clinically and we do see over the course of rehab that they're worsening in pain and their function is getting worse, maybe we can't be totally confident, but we might be able to, with this research, come to a conclusion that their tear might be progressing. And maybe after the course of, we send them off a year later, they come back to us and they're like, hey, Dan, I've been working on your rehab program and my shoulder's just been aching the last couple months. Things seem to be going in the wrong direction. Maybe they are making the tear a little bit worse. And then, we'll send them off to the surgeon for maybe another consult and see if things have progressed. But I guess it's useful information for those specific cases that we know are probably going to progress. Maybe we get them in a little sooner. But otherwise, maybe we just really do a good job at monitoring strength over time and pain over time and their reported function over time and see if we feel like there might be a progression going on.
Yeah, for sure. Good points there. I guess I have a few thoughts as well. We'll talk about this in a minute, but I think the first one is like, we're trying to save healthcare dollars, obviously, but these, I think, is one of these situations where getting MRIs over the course of time is probably going to be a decent idea. Like if I knew that I had a full thickness rotator cuff tear and my pain is staying pretty stable, maybe every year or so, I'd love to get an MRI just to see how this thing is going. Right. I know it's often like we're trying to keep people from getting these MRIs, but in some situations it might be good. And it wasn't this study, obviously, but I can't remember the study where I read this. But so there's a few things that also correlate with potential worsening. And one of those is a new onset of pain. So if your shoulder gets kind of stable and then like 2 years later, you feel a new onset of pain, you could have actually had a cuff tear progression at that point, right? The other one's smoking. And I think a lot of those comorbidities also. So like if you have diabetes, you have high cholesterol, right? You're a smoker, probably more likely to progress a little faster as well. Obesity, potentially one of those as well. So yeah, a few things to think about. I think that naturally brings us to our next point. When do you think these folks should get surgery and when shouldn't they? What do you think, Evan?
Ooh, yeah, again, a lot going into it. I think with all the statistics you went over, and then paying close attention to the patient and their long-term goals, right? If this is a person with a pretty painful shoulder and a pretty decent size, like partial thickness or full thickness tear, and they want to get back to CrossFit and performing Olympic lifts, and they're younger, I mean, to me, that's like a no-brainer. But there is a lot of gray area, definitely.
Yeah, for sure. I wrote a list of things down because this is one of the things I kind of go through this thought process for patients. I think the first one is partial thickness versus full thickness. Like if someone has a partial thickness tear, I'm almost never sending them back to the doctor to consider surgery unless they're making no progress whatsoever. And then in that case, I will. And I've actually had a few patients where they've had success. Either they had a partial thickness repaired or they progressed to a full thickness and they had it repaired and they did quite well. I think the other one is how large is this tear? Is it fully retracted? And two thoughts, right? So if you have a retracted tear and it's large and you have a patient that's like 75, right? And they're happy with their life, happy with their function. And I think that it's reasonable to just say, hey, let's just do some conservative physical therapy with this thing. But if you have a patient that's like 40, we've had a couple of them recently have like a large or massive cuff, tear, and the surgeon believes there's a shot of repairing this, I'd probably repair this thing. You know what I mean? This person has another 40, 50 years of life ahead of them. And especially if they're fit and athletic and they want to get back to higher level stuff, like probably want to get that surgically repaired as soon as you can. Because if that keeps on going, you're not going to have a shot. And you probably have a non-functional shoulder for a while and you don't have any more surgical options at that point. You know what I mean? So the other one's tissue quality. So if you have really good tissue quality, better likelihood of the surgery doing well. If you have terrible tissue quality, obviously not quite as good. Comorbidities, we talked about that before. Age, I think, is really important. We discussed why. If you have someone that has a larger full thickness cuff tear, potentially massive, there's an opportunity to repair it and they want to be athletic, probably try to repair that. Whereas if someone's 80, they're doing all right. They just want to be able to like have a little less pain in the shoulder. Maybe just physical therapy is the way to go. I think the other one that's a big question mark, I'd love to know a little more about. And I ask this to surgeons frequently, and I know this is something that surgeons will present to patients, is that what do you want to get back to? Are you trying to get back to CrossFit, powerlifting? You trying to get back to volleyball? Or are you just like trying to be successful putting like mugs into your cabinet for the rest of your life? You know what I mean? And if you have a high level athleticism you want to get back to, maybe that surgery is the right choice if you can't get back athletically with basic physical therapy, right? So who knows? Any thoughts there?
Yeah, totally. Always just comes back to patient-centered care, right? What's their end goal and where are they now? And is surgery the best option for this person, or is this something we should work on over the course of time and see how it goes?
Yeah, good stuff. And last thing, I already mentioned this, but I do recommend patients go back for some additional imaging if they have a large partial or full thickness cuff tear. I'm thinking about one gentleman in mind where he had a shrug sign, right? He had rotator cuff related pain. He's very strong, right? Didn't seem like he had a massive cuff tear, but he had that shrug sign, which is a little interesting. Had some decent pain. Went in for some imaging, and he had I think it was a large partial or full thickness, and just treated conservatively. And then he got better
the point where he didn't feel much at all. 2 years later, new onset, very similar symptoms. And I actually did recommend he go see the doctor at this point, just because we want to make sure that we're not dealing with something that's a lot worse. And, lo and behold, he did quite well. He got back to where he needed to be without any sort of surgery. But I did want to know that he wasn't dealing with something that was a lot worse than what we were dealing with previously. So I don't think that's a bad idea.
Okay, so let's say you end up having a patient going through rotator cuff repair surgery. They're coming into your clinic and you're trying to figure out how to do the best job possible. In this next part of the video, we go over a consensus statement which summarizes the literature on how to best treat folks with rotator cuff repairs. Hope you enjoy this one.
All right, Dan, you ready for this paper?
I'm ready, Kevin. Let's blast through it.
Nice. So this is it's the American Society of Shoulder and Elbow Therapists. They came up with a consensus statement for rehab following rotator cuff repair. And I think a lot of people might have heard of the American Shoulder and Elbow Surgeon. And that group is they work with this group of therapists as well. So they publish in the Journal of Shoulder and Elbow Surgery.
Love it, dude. Love it.
So yeah, this is less of a classic study, but a consensus paper, right? So they talked about why they thought this was really important. So these people, they're a group of physical therapists, occupational therapists, and athletic trainers, and they just love treating the shoulder and elbow. It's their big thing. And I think what they found is that there are so many rotator cuff repairs being performed. So this was written in 2016. So at the time, they were saying about 450,000 rotator cuff repairs performed per year.
Dang.
That's a lot. That's a lot. And then it says over $7 billion per year, right? So that is wild. And you can only imagine in the last 8 years that has increased, right? At the time, also 95% of those were arthroscopic. But again, I don't know. I've never seen an open rotator cuff repair. Have you seen any of those? I mean, probably not recently, right?
Not many. I want to say one or two. And I think usually it's if there's something else weird going on with it. They might do that, but yeah, not really.
Yeah, I guess actually we do have one now I'm seeing with Lenny, but it's there's a lot of other stuff, right? I think it was 3 tendons and damage to the axillary nerve. So
yeah, that makes sense. Yeah.
Yeah, but by and large, this is not something that we see often. But anyway, the authors of this paper were seeing that there's really a lack of consistent treatment protocols, right? I mean, one thing that we really are in need of is something where there's a bunch of evidence supporting a protocol. And specific surgeons have their own protocols. I do think a lot of times, obviously, those would be evidence-based, but to date, there was no consensus statement, right? So I thought this would be good to go over, and I'm not going to go over the whole details of, week 1, start here, week 2, go here. But I do think the methods that they use to gather this information, it's kind of like they did all the tough legwork for us. And, they came up with a paper that makes a lot of sense in terms of when to start certain things in rehab and what to look at over the course of time.
Yeah, I agree with you. I mean, I say this a lot, but it's kind of funny. Like you may have a patient on Monday morning comes in, rotator cuff repair, large full thickness, week 4, right? Let's say they don't have any sling. They're already doing passive range of motion, so on and so forth. Protocol has them starting, resisted stuff a week 6, right? And then you have a patient comes in at 8 a.m., same exact thing, full thickness rotator cuff tear, different surgeon. They're in a sling for 6 weeks, passive range of motion until 3 months, resisted range of motion at, month 4. You're like, what the heck is going on here? There's just like a tremendous variation in what surgeons want in the protocols from patient to patient. That doesn't make any sense at all, right? We should have some sort of consensus. So obviously I agree with you. We just need to have papers like this that basically tell us what should we be doing with our patients, right? Obviously, a little variation from patient to patient, surgeon to surgeon, but it shouldn't be an enormous difference, right? It should be kind of similar.
Exactly. Yeah. And I think what was good about this is the journal it was published in, the Journal of Shoulder and Elbow Surgery, is this is a journal that goes out to physical therapists and surgeons. So, I think the goal here is that it's a protocol with good evidence in theory that everyone's on the same page with, right? It's not like you have a surgeon who's sending their patient with a specific protocol and you're just going to follow this and completely override them. Hopefully, the surgeon is reading these articles as well and everyone's on the same page. So just a little note about the consensus statement is, as a consensus statement, it's level 5 evidence. So we're looking at expert opinion, but it is based on a lot of research, right? So they scanned a bunch of the databases, and what they've ended up landing on was 14 articles, and those included randomized controlled trials, systematic reviews with meta-analyses, and 103 other articles on mechanistic studies. And this was an ongoing process that they described in the paper, where from its inception, they would have a small group of therapists working on the legwork of reviewing the research. And this was something that was discussed at several annual meetings. And it was consulted with the surgeons. The surgeons would give their input, and it would go back and forth and back and forth. And then finally, it ended up in a published paper in 2016. So they put a lot of time into this, and I think you could tell by the article. I think they did a good job.
Yeah, I think it was pretty thorough. Unfortunately, it's not open access, right? Because they did have some pretty good recommendations. And we'll talk about some of this today, but we're not going to go in depth, but kind of like what to do week 0 to 6, 6 to 12, so on and so forth. We'll cover some of that. We'll try to give you the broad strokes, but I liked how everyone met up. They used research to try to figure out what's the best practice at this point, right? I mean, unfortunately, we don't have, well, there are some, but basically pitting randomized controlled trials, one protocol versus another. I will put a link in the show notes because I did go over a lot of these questions, like when should we start range of motion? When should we start like resisted exercises, so on and so forth. I try to answer some of this. And I'm not even sure if they included most of these studies because they may have in their recommendations. It sounds like they did some of that.
Yeah. So as the article started, one big thing that they were focusing on, that there's a lot of discrepancy between providers and surgeons, is when to start range of motion. So one thing I will say is the study included all types of rotator cuff tears. So they had partial thickness, and they had large and full thickness rotator cuff tears as well. But I think they do give specific recommendations as they get into the weeds a little bit about the difference between the full thickness and the partial thickness in the early stages of rehab. But I think enough of the rehab is consistent surgery to surgery that, these little differences, they work out over time, but the theory around it is still the same, right? So in terms of early mobilization versus protected healing, I guess the debate here is that early mobilization, we might be able to prevent long-term stiffness. What seems to be interesting about that is when they look at this long-term. So there are some studies that look at, a year out, more motion in the first 3 to 6 months. It doesn't necessarily mean long-term more motion, right? So maybe you're getting someone in and you're mobilizing them and you're thinking that this is going to be really helpful at preventing long-term stiffness. Well, long-term stiffness isn't really a concern for most rotator cuff repairs. Most do pretty well getting their motion back. And the authors were pretty adamant about that, is that, there are risks to mobilizing early. And one thing that they noted was there's almost a 2 times higher risk of re-tearing. And, the more motion in the first 3 to 6 months, it doesn't necessarily equate to the long term, right? So we're trying to balance, and they're trying to figure out, and their question is, when do we start that early mobilization in physical therapy? So that one school of thought that you start, post-op day 1, 2, 3, they talk about some pros and cons of that. And, I'll get into their ultimate conclusions, but for early mobilization, there's potentially some pros, but I think I agree with the authors that we'll get to their conclusion, but potentially more cons in that early mobilization. What do you think about that, Dan? Do you see protocols that start like super early and they want you to do passive range of motion in the first week or so?
Yeah, some, not a ton. I would say most docs, especially in the Boston area, seem to be a little bit more conservative. I love talking to Lenny. Hopefully, we'll get him on the podcast at some point because him as well as Mike Reinl, they were down in Birmingham with James Andrews, Kevin Wilk, all those guys. And, very specifically, the rotator cuff protocols are fast, right? They're doing isometrics right away, range of motion right away. And that differs a lot from a lot of the other protocols I've seen over the course of time. So, um, I guess you're going to get to this, right? But most of the research I've read is that if you have a small to medium cuff tear, early mobilization doesn't seem to influence re-tear rate, but it certainly does for the large, right, or full thickness. And for a lot of docs I've talked to about this, that's their exact reasoning. They're like, long term, it's going to be the same. Why the heck do we need to get started right away? And I think there is a little bit of a counter argument there we can talk about a little bit later. But yeah, if you're going to keep people safer and you have a similar long-term outcome, then why the heck would we want to get started right away? So, I mean, you could. I mean, you reduce pain, improve range of motion early on, obviously, but yeah, at the expense of potentially re-tearing. Like, I don't know if that's something I would like to do.
All right. Well, speaking of the counter argument, Dan, there we go. The group that wants to do protected healing, so they say, let's not early mobilize. Let's wait a little bit. There seems to be a lower risk of re-tearing, and it doesn't lead to the long-term stiffness that sometimes the early mobilization group thinks that if we go ahead and mobilize this thing early, they're not going to be stiff in a year. That doesn't seem to really pan out. One negative of waiting and not getting the person into PT early, I thought this was fascinating. If the patient is less compliant with their precautions, so say the surgeon says, hey, go start PT in 10 weeks or 8 weeks, and just hang at home in your sling for the early, let this thing heal, let this thing scar down a little bit. Well, if that person isn't educated and they're checking in with a therapist and making sure they're following their precautions, they're 152 times higher risk of re-tearing, which I thought was just insane, right? So,
That is insane.
those patients that I've had plenty, I'm sure you have, that they're not in PT, they're not getting educated on what things to avoid. So, in terms of just getting in for the mobilization, I think when we're mobilizing, a lot of times we're educating throughout that process, right? That's something Lenny talks to the students about all the time. When he's mobilizing and he's passively ranging a patient, he's talking about their day. He's seeing how they're feeling. He's being goofy, but he's also educating, right? So I think one of the cons of the protected healing, if we're really going to wait a long time, is that we don't get to see this patient in physical therapy, and we don't get to educate them week in and week out and make sure, maybe they're feeling a lot better week 6 or week 7, and they're getting a little loose with their precautions and contraindications. And then we know if they're not compliant with those, they're at a way higher risk of re-tearing. So I thought that was fascinating. So, early motion, late motion, they do come to a conclusion that we'll talk about, but I didn't know that about the compliance, but it makes total sense. And, I think as PTs, we're great at educating. So if we're not seeing these people, maybe they're not getting the education from the surgeon, or that was so long ago that they're forgetting what they should and shouldn't be doing.
I just thought that was crazy. Like the math is nuts, right? 152 times. If you've already got let's say a 25% chance of re-tearing, you multiply that by 152, like that doesn't make any sense. It's like a 10,000% chance of re-tearing.
Yeah, infinite percent. You tore it already, actually.
That's pretty funny.
So in terms of just the range of motion, the authors kind of concluded that what they like to do best is for partial thickness tears, they're thinking to wait 2 or 3 weeks. So let this thing calm down a little bit after surgery, and then get the person in, and you can start some protected range of motion. So protected range of motion being like flexion up to 90 degrees, external rotation at 0 degrees of abduction, maybe just 20 or 30 degrees, but you're just getting the sling off and you're gently moving this thing after the first few weeks. But then they are quick to note too, if this is a full thickness rotator cuff tear, maybe we wait those first 6 weeks, and that's going to be the surgeon surgeon's decision. They understand from being in there the tissue quality and all the other factors that went into the surgery. And if this is someone who is at a high risk of re-tearing, let's wait a little bit longer. But for other people, the authors were pretty quick to note that there's no good evidence that we shouldn't start mobilizing after that 2 or 3 week mark. So that's kind of what they conclude here. And what I liked about this is, they go through all the evidence and they kind of say like, hey, here's your risk of re-tearing. If it's a certain thickness, your risk of re-tearing in the first 3 months is way higher. If it's a partial thickness, your risk of re-tearing in the first 6 months is higher. So be cautious and really stay within the range of motion guidelines that they give. And hopefully you're doing your best to prevent that re-tearing. And then they just talk about that anatomic failure, although it's not uncommon. And this is something that, I think we talked about on a previous podcast, but for function, if it does seem you do have a re-tear, it may not matter in the long term, but I'm sure that totally depends on the size of the re-tear, right? If it's a very tiny bit, maybe it doesn't matter. But if it's a big re-tear, that's probably going to affect your pain and function. But we do want to try to minimize that as much as possible. And then it usually happens in the first 3 to 6 months. So we definitely want to be careful in that time period, that we're not rushing through the protocol and we are following a protocol like this.
Like it. I imagine you're probably going to talk about this a little bit later. In terms of the size of the tear and the tissue quality, I think by tissue quality, we kind of mean, is there fatty infiltrate in the area? Is there like a calcific tendinopathy going on, something along those lines? And we actually going to do a whole podcast on this, but you can kind of figure those things out just by getting a surgical report. And I also email the doc and say, well, what's the tissue quality like? And like, oh, it's good. I'm like, all right, great. Well, I'm not as concerned. I can probably end up speeding things up. But if it was poor tissue quality, we're just like crossing our fingers and waiting a little longer and hoping that thing just like kind of re-anchors down and scars down, just like you said. So, it's going to depend on what the patient has. And obviously talking to the doc is going to be important to know what's going on before you start, unless it's written well. Some surgeons are good about writing how fast they want you to go or why. Other surgeons not, right? Like some surgeons don't even know what protocol they're sending over with their patients. So you kind of have to do your due diligence a little bit there. And sometimes you have to kind of do a little extra work that you wouldn't like to, just because, you don't always have a protocol that's accurate or you don't have the extra information you need.
Yeah. So then instead of, going through every single thing that they mentioned in the protocol, just kind of summarizing the author's conclusions. So they had certain recommendations of things we want to track over time. So they call these KPIs, or key performance indicators. And so what we're looking at here is external rotation range of motion at 0 degrees of abduction. How is their external rotation progressing? As that gets better, it seems like the patient's overall function is improving. You could almost think about it as like an outcome measure for this type of surgery. Same with flexion range of motion. So if I have someone coming in after a rotator cuff repair, what this protocol is recommending is that, when the time is right, this is something we're measuring perhaps each session and making sure that it's trending in the right direction and that it's something that the patient is working on their own. But of course, they didn't mention this, but I think something we always try to focus on is the patient's specific goals too, right? Are they progressing towards those specific goals that they came to you for? And it was the reason they got their rotator cuff repaired in the first place. So we're making sure that we're checking in on that with the patient. And then another thing that we want to track over time is stiffness. And as the authors mentioned, this is not common long-term. So there are a subset of patients that do seem to get stiff, and they're people that we might spend more time doing passive range of motion on, or other soft tissue modalities or something to improve their range. And this is generally patients with diabetes, type 1 or type 2, I would say, certain type of thyroid disorders, people that had acute tears, or if they're developing an adhesive capsulitis. I mean, these are people that we need to give additional attention to for the range of motion. But what do you think, Dan? Do you ever look at that external rotation at 0 and flexion over time in these patients, or do you have any specific indicators that you like to look at?
That's pretty interesting. I never like specifically knew about the external rotation at 0 degrees. But certainly if a patient is having a lot of trouble with range of motion or they're having a lot of issue with pain, I will try to get the surgeon back on board a little sooner. I'll just recommend they reach in. Hey, is this normal? Are you concerned with what's going on over the course of time? Right. Just because I just, you get burned sometimes, and not just in the shoulder, but if someone's having pain out of ordinary to what they normally have, or they're extra stiff, not progressing along the lines where they should. If there is something more serious going on that we would like to know about, probably contacting the doc sooner than later is important, right?
All right. So the next category that they focus on is muscle performance. So strengthening. They recommend using active range of motion with a short lever in a gravity eliminated position. And one thing that I thought was great that they did is they referenced a bunch of EMG studies, and they're looking at specifically EMG of the supraspinatus. And in their phases, their phase approach for rehab, phases 1 through 4, they're they're really good about keeping that EMG level low. So with the exercises you're giving the patient in the first 2 phases, we're really trying to keep the EMG level below 15%. And I think this is good because it gives us confidence in our interventions that we're not overloading the tissue. I remember when you had Dr. Rocket on the podcast. It was a great podcast. Go back and listen to it. But he was a
Listen
big
to it.
fan. Oh yeah, he was a big fan of waiting until 12 weeks to start strengthening, right? Because that's how long it kind of takes these things to heal, and we don't want to do anything to stress the cuff unnecessarily in those first several weeks. So what they look at here is progressing by time and also progressing in terms of the load on the tendon. And I thought the use of the EMG was pretty cool. I know that there's a little controversy with EMG on social media, just like everything else on social media, but I like the rationale behind it. So just one quick example. I mean, their protocol has like all types of things, but they might progress a pendulum in phase 1 to like a towel slide on a table where you're using a little more, perhaps supraspinatus, to a forward elevation pulley, where again, you might be more in that 16 to 29% EMG versus that early pendulum. And then something like scapular rows, and then progressing over time to like a 10 rep max series of dumbbell exercises. So I think the way they lay out these progressions makes sense. And again, it's based on the EMG of the supraspinatus. So we're really thinking of taking caution and not overloading too early. So, I think you can be creative with the patient goals, right? Like maybe for Dan's patients, when we're in that phase 4, dumbbell exercises might be a piece of it, but maybe we're getting back into some barbell lifts too. And we have the patient's long-term goals in mind, but it's within this framework that was given by these authors. I think makes a lot of sense. What do you think, Dan?
Yeah, for sure. I think that I'm trying to remember like what phases. I think their phase 4 plus was at 5 months, right? And I think phase 1 was like 0 to 6, and then phase 2 like 6 to
Yeah.
12, and then 12 to
Yep.
20, something like that. And
Yep.
phase, yeah, 3. I will say that we already talked about this a little bit. EMG stuff is hard, right? I did all those social media posts and I tried to look at EMG of different exercises, and like it makes like no sense whatsoever, right? Which makes it really, really tough. And then we also know that EMG isn't perfect, but I think it's a decent way to start. But like you'll even see like a push-up plus being like 110% MVIC of supraspinatus, and you're like, well, that's kind of crazy. Like if I take my arm up here, right, into abduction and like push as hard as I can, you're gonna have the same amount of EMG with that as like a push-up plus, which you're like, really? That's crazy. So I always wonder, like, are these EMG studies accurate? Is like the needle not placed in the right place? Like, what the heck is going on here? But yeah, I do think that using EMGs as a goal is smart and progressing from easy to hard. Another thing I think they recommend in this study was going from like passive to active assist, right, to resisted range of motion. What I will say is that, and we may go, stop me if we're going to go over this in a little bit, but I went back and kind of compared this consensus paper with our protocol that we use at Champion, as well as a Delaware protocol, because I like that one a lot too. And
Mhm.
even in like the let's say like a large or massive cuff tear, let's say with retraction, the Delaware protocol and especially the champion program is a lot faster than what they recommend in the consensus statement too. So I always wonder, right? Like what's the best way to go? I would say that this consensus paper looked like it was saying we're treating everyone like a large or full thickness rotator cuff tear. And my personal opinion was like, well, for the smaller medium, maybe we can go faster. And historically, I've definitely gone faster in a lot of ways compared to this paper. But those are my initial thoughts anyway. So
Yeah, no, I think that's a good point, right? I think they're probably going to go in a paper like this with the more conservative route because that risk of re-tearing, they're probably thinking, let's make sure we don't hit that re-tear. But I think at least in the early stages, to me, it made a lot of sense, right? And then using clinical judgment and tissue healing timelines and cross-referencing some of the papers that they cite, I think would be good.
yeah.
Yeah. So then on to the next one, something that they spent some time talking about was the importance of patient education, right? So how do we modify activities early on? How do we, if we're trying to reduce the load on the repaired tendons, how do we teach the patient to do things differently so they don't re-tear? The other big thing is talking about compliance with the home exercise program. I've had patients who they're like, I don't know why, I definitely had a guy in my first job who retore. And he was doing his exercises and he was good about them, but he was just doing so much more at home. He came in, I think we were like 6 weeks out and he built a chicken coop and he was like, dude, I'm just using my other arm. I'm not using my repaired arm. And, he was compliant with his exercises, but I think that, I might have failed educating him and just like, dude, you got to be super careful. He had a bunch of other comorbidities, right? So maybe he was bound to re-tear no matter what, but really educating on, activity modifications and what you should and shouldn't be doing at home. And then the other thing is educating the patient, perhaps that, this is something we're looking at over time, whether it's that external rotation at 0 or your overhead lifting. And we just want to make sure that this is slowly progressing in the right direction, right? This is something you can test on your own and you just make sure weekly, if you're not coming into PT every single week, make sure these are heading in the right direction. And then we kind of know that, even if it's going slow, we're kind of heading where we want to head with the rehab program.
Yeah, that makes sense to me. I think, I've had some rotator cuff tears, re-tear. It's just a math thing. Like over the course of time, if you treat enough rotator cuff repairs, it's going to happen, right? And I do think that, and I talk to students about this, is that it seems like at least with the rotator cuff, we have a decent amount of influence on whether or not this does re-tear. So it's something we do have to be really smart about. It is a little tough because what we're doing in physical therapy is probably way less what the patient does at home. Lenny always talks about that study where if you open a door with your contralateral side, it's going to be above that 15 to 20% MVIC EMG of the supraspinatus. It's like literally you have to be careful with what you do with both arms, right, to keep this thing safe. And I'm usually fairly aggressive in terms of, let's say, if you have some sort of surgery, training that contralateral side limb. But for rotator cuff, I don't want to do too much of that early on because we know that we're probably going to get probably too much activity, right? EMG of the cuff just by training that opposite side limb. I think that's important that patients, or excuse me, even other physical therapists learn this because I've certainly seen folks that have had rotator cuff repairs and they're in the gym trying to train the other side. And it's like, I don't know, you might be, I don't know, playing with fire a little bit there. So I do agree with you. The home exercise program compliance is very important. Following these precautions is very, very important. And even if you are using the other side arm, you probably want to keep it easy on that side too, right?
Totally. Yep.
Yeah.
Awesome. Yeah. So just some final thoughts here. Again, I didn't go into each specific week. I didn't think that was absolutely necessary, but I think this is a great type of paper for early career professionals where we're really looking for guidance in how these papers are made and these expert opinion papers. I think these people deal with this all the time, right? So they're good people to learn from. And it makes sense logically to me. I think it's important that we always remember our patients deserve evidence-based care. They deserve the best treatment we can give them. Um, if you have a surgeon's protocol and it really just looks like um, something that's not based in the evidence, which does happen sometimes. Like Dan said earlier, sometimes the surgeons don't even really know what protocol is being given out. Maybe it's just the hospital that gives out a certain protocol. So it's never a bad idea to reach out to the surgeon. And if you have specific questions about the protocol, what I like about it as well is that, I think as a profession, we need to get better about streamlining care, right? If you go to 10 different PTs, you can't be told 10 different things and get 10 different plans of care. And, some PTs are starting you on, pendulums day one or active motion day one. And it's just all over the place, right? I think these protocols, we can use our creativity and our exercise selection and the patient's preferences and their goals to tailor the plan of care. But we definitely need some better ways of treating these common things, and we need to be doing it in a similar fashion. So I like these type of papers from experts. I think a lot of social media right now poo-poos expert opinion and don't think it really matters much. But I still hold it in high regard and just understand that it's not a randomized controlled trial, but I do think it holds a lot of value.
I agree with you. I said this in the beginning. There should be some sort of standard or consensus on the way we treat these things. Like if I went to a surgeon and I had brain cancer, right? And he tells me you need this procedure, and I go another one, they're like, nah, wrong procedure, this procedure. And I go to another one, they're like, no, this is wrong, do this. I'm like, whoa, that's not good. I mean, I run into this problem with dentists. I've had two dentists. The last one told me something completely different than the one I just have more recently. I'm like, who's right? This is crazy, right? Like if they were like a little closer and said, well, I like this procedure, but this is the way I like to do it for this reason. And the second surgeon's like, yes, this is the gold standard treatment, but I may change it a little bit based on my own skills, whatever it is. Like, great. But if it's entirely different, and oftentimes you get this with physical therapy, like different physical therapists give you something different, where surgeons have wildly different protocols. Like that's like a red flag in my mind, right? You want to see at least some consistency. So yeah, I think papers like this are really important, where we have some of the smartest minds in the world getting together to at least give some recommendations based on some of the research we have. So thank you, Kevin, for enlightening me today on this subject.
My pleasure. And I actually do think it is open access. I think if you go to like the link that we'll provide, I think there's like a full text view. So hopefully people can see this and can look through it themselves, because again, I think it was a good progression and helpful to see the why behind it. I think is the most interesting thing to me.
In the last part of today's video, we go over 4 keys to operative rehab for folks who've had rotator cuff repair. More specifically, we talk about how we apply the best practices for rotator cuff repair to make a lot of this information more practical for you, give you some good takeaways. I hope you enjoy it.
I was just gonna say, why are we even bothering going over this, right? Well, I think the big thing is that cuff tears are incredibly common, and then with surgeries, re-tears are very high, right? Especially in the first 3 to 6 months. So with that, we have to have some certain things that we care about in the rehab process. There are keys here that we want to follow. Um, we have to understand that larger tears are at higher risk earlier of re-tearing. But what we're really here for is to advocate for the patient, right? So we're trying to do what's best for the patient with these 4 keys, and understand that with the patient, with the surgeon, with us, with everyone involved, that teamwork is really what it's all about in helping the patient succeed.
Teamwork makes a dream work, right?
Yes, as someone
Yeah.
wise once said.
Yeah. I really agree with this. I don't know if you kind of listened to last podcast, we already mentioned this a little bit, but this is important for physical therapists to understand, because we can hurt patients, right? There is a higher re-tear rate for these surgeries, unfortunately. And what we do as a physical therapist is going to dictate potentially if you have a re-tear. So it's really important that we understand these things. And there's a few like basic major principles to keep in mind that can really help you out. Not trying to scare physical therapists, but unfortunately, these repairs do have a relatively high re-tear rate. So if you see enough of these, you're going to have a re-tear here and there. Not the end of the world. It just kind of comes to territory, but we're trying to minimize these as much as we can, right? If we can. So what do we do first, Kevin?
Oof. The number one thing here is I think we need a copy of the surgical report if we can. That's super important. And it's something that early on, I definitely was probably more focused on the protocol than obtaining the report, right? And I think that most surgeons are definitely willing to give this out. So a lot of times the patient will come in with this, but a lot of times they won't. And it's as simple as calling the surgeon's office. And I've called surgeons a bunch of times and I almost never speak with the surgeon. I speak with the nurse or medical assistant that sends over the information. And then if I have further questions, maybe I can talk to the surgeon. It really depends. But it's simple as calling over and just saying you're a PT working with a mutual patient and you'd really like the surgical report so it can help your clinical decision making. And they're going to be willing to give that to you. So it's important for a bunch of reasons. The first thing you want to know is what tendons were repaired. Was it one tendon? Was it just a supraspinatus? Was there multiple tendon involvement? That's going to implicate many things. Our education for the patient, potentially. If it was a subscap repair, they need to know what motions to avoid early on and to be more careful of. It's going to affect our passive range of motion and exercise selection. We don't want to put unnecessary stress on this too early. So understanding what tendons are repaired is huge. Another important one is the size of the tear. Again, we've gone over this in previous podcasts. But we know larger tears are at risk of tearing sooner. Especially within that first 3 months, it seems like most of these that will re-tear do. So we want to be cautious. If this was a very large tear, let's just be a little bit more cautious and conservative in our first few months. We got to think long-term with this patient, and that information helps us make that decision. The other thing when we're talking to the patient is we want to understand their general health and comorbidities, because again, when people have these comorbidities, it totally plays a role in their chance of re-tearing. We know from the evidence that if someone's obese, they have diabetes, they smoke, they have high cholesterol, they might be at higher risk of re-tearing. So maybe for that specific person, we just take it a little bit easier early on and we don't go so fast. And then the final one here, I think with the surgical report that you get is the surgical technique. And this is one that honestly, I don't know a ton about, but I think if it is something that's very important to the surgeon, they'll make sure you know. And it's something you can just ask. You can call and ask, hey, this specific surgical technique, is there anything I should change about my rehab process because you did a double row or anything like that? And they might just say, no, go ahead and follow the protocol as written. Nothing else to worry about. But unless you call and ask those questions, you're kind of guessing. So we want to make sure that we do call and we get all the information we need.
Nice. Yeah, definitely agree with you. A couple ones I wrote down there. I think for one, another important reason to get the surgical report is that sometimes there are additional procedures that are performed, right? Patients aren't really great at saying what they had. Like, oh, I had my rotator cuff repaired, right? And then you see what actually happened. And there's like 3 rotator cuff tendons repaired. And on top of that, there was a biceps tenodesis, right? There's actually a whole bunch of arthritis. It took out a bunch of bone spurs. There's like a bunch of crazy things that happened and you had no idea, right? The post-op report will definitely let you know. But yeah, if you have a biceps tenodesis with like a supraspinatus repair, you have to be really careful with elbow flexion, right? And you didn't really have to be careful with elbow flexion prior to that. So without that knowledge, you're not really keeping the patient as safe as you could, right? And Kevin already mentioned this, but the size of the tear is very important. So if you have a large or massive rotator cuff tear, probably got to go slower than the small or the medium ones. And that's going to be when you incorporate things like passive range of motion, and then when you start to progress towards active as well as resisted range of motion. General rule of thumb, it's usually somewhere between 2 and 4 weeks difference, right? So if you have a smaller or medium cuff tear, maybe you're starting things a little bit sooner, 2 to 4 weeks. You have a larger, massive, 4, even up to like 6 weeks, a little bit slower, right? Just because we really want to make sure that thing scars down as much as possible. like Kevin said, most of these tears are going to occur within the first like 0 to 12 weeks. And you'll actually have a lot of folks that actually tear within their sling, which is kind of crazy, just because you would think they're not doing anything, but that does happen, right? We're trying to protect these folks as much as you can. And then a little bit to the technique. And again, this is not my strong point whatsoever, but you can ask the surgeon this, and I will ask, if there's a difference. And sometimes surgeons are like, well, it doesn't really make a difference, right? But there is some research about like the double row technique is a stronger fixation to the bone, which theoretically could handle a little bit more sooner on compared to something else, right? I will also ask the surgeon about tissue quality. So was there a lot of fatty infiltrate, calcium? What did that tendon look like? Was it in good shape? If it's in good shape, then I'm just a little bit less scared to push. If it's in terrible shape, probably want to slow things down again, right? All those things. That makes sense. What do you think, Kevin?
Yeah, those are great points. I think it's hard to think like the patient thinks, and a lot of times they don't have the same background as us in terms of understanding anatomy, or they're not as curious as us about exactly what happened. So that's a great point. They might have also had, like you said, a biceps tenodesis, and they just said they had their, rotator cuff repaired. So that's great. Yeah, that's other information that you'll need. So I think key point number 2 is patient education, right? We are here to educate the patient through the process. We're here to guide them and help them heal. And whether that's from something like medication use, they might have been given a bunch of, say painkillers from their physician, and they're unsure when they should stop. Sometimes they do get good advice on this. Sometimes they don't. And the other thing I think tied in with medication use is understanding when they can drive again. We always tell people that you definitely have to be off your pain medication to drive. So that's one thing. The big one that, we talked about in a previous podcast is understanding precautions and contraindications. So if these patients don't know exactly what they should and shouldn't be doing early on, we know if they're not following their precautions, they're at a way higher risk of re-tearing, right? So that's something we want to be careful with. And then Macho Man versus Nervous Nelly. So what this means, let me decipher that, is the patient early on who is very confident that everything's going to go well. They feel great and they're doing a lot at home. We have to educate them that even if they feel great, we're happy that they do. They have to follow these certain procedures in the right order. We can't just skip steps when we're looking at something like tissue healing. Tissue healing timelines don't vary too much person to person. It comes down to their basic anatomy, and we have to be good at educating them. Hey, slow this down, get through this first, X number of weeks or months, and we know you're going to be in a better position after that. I think same goes for the Nervous Nelly type presentation, right? We see people who are so scared of re-tearing that they don't want to move their arm at all. And honestly, I'd probably rather have that person early on than the person that's way too aggressive. But you do want to, educate that patient that, hey, these procedures do really well long term if you follow the precautions and contraindications early on. If we kind of go stepwise here, you're very healthy, you have good tissue quality. I think you're going to be successful, but we just want to follow this step by step and don't be too scared, right? I think that's a big thing. I wouldn't tell that person, hey, re-tear rates are anywhere between 17 and 94%. So good luck, right? They're going to hate you and they're going to be very freaked out. So I think choosing the right words with these people is so important, knowing who you're talking to and educating them the right way, not purposely withholding information, but framing it the right way. Hey, Nelly, these do re-tear if we're kind of goofy and not, paying attention to the contraindications, and we're not doing things that we're supposed to. So let's give this the best shot we can at healing. And then on that point, it's just following the rehab timeline, making sure you have a good protocol, educating the patient. And then if this person's come to you and they're a, CrossFit athlete or a power lifter, and they have long-term goals of returning to competition, we want to show them and talk to them in that initial session about, hey, I know we're 3 weeks out right now, but let me just show you the timeline here. Let me show you where we're at now. Let me show you how we're going to get back to Olympic weightlifting, or, doing kipping pull-ups, or, chest to bar pull-ups, right? We're going to get back to these things. And this is kind of what the rehab approach will look like. And I think seeing that can get them excited early on. They can see the long-term goal, and then they feel like they're an active participant in this process. And all they have to do is follow your guidance.
Yeah, I agree. A lot of good stuff there. I agree with that nervous Nelly and the macho man, right? You're going to get some people from time to time, and it's not even just a macho man versus nervous Nelly thing. It's that they just feel great, and they feel great way too early. They come in like post-op week 3, no sling, massive rotator cuff repair. And they're like, I feel good. Look what I'm doing with my arm. And you're like, whoa, 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 whoa. You're going to re-tear this thing, right? So that's really important to educate folks, especially the ones that are feeling pretty good. And you're probably going to have this spectrum, right? And you see the spectrum with other injuries that aren't just like rotator cuff repairs, but there's going to be folks that overdo it classically. There's going to be folks that underdo it. And I think a lot of your communication is revolving around what type of person you have in front of you. And again, social media, I mean, we don't want to scare people necessarily, but giving people this information, I think, is helpful if they're the type of person that does too much, right? And the other thing is that if I had my rotator cuff repaired and no one told me that I couldn't do something early on and I retore it, I'd be mad, right? So I think you're just being honest with patients. Like, let them know, like, you have 152 times increased rate of re-tear if you do a whole bunch of stuff you're not supposed to early on, right? That's kind of crazy. I want to make sure that I don't repeat this surgery. The surgery is actually a really tough one, right? You also talked about the timelines, which I think are going to be really important and also helpful for patients. So I get a lot of patients that are like post-op week 6 and like, well, when can I squat, right? When can I bench press? Am I going to be able to overhead lift? When can I do kipping pull-ups, right? Or they ask you all these questions throughout the course of rehab. It's like, can I start doing double unders yet? Or how about box jumps? And they're just constantly educating people about what's maybe okay, what's not okay. And then also educating about the process leading up to that. So you can at least see that they're progressing over the course of time. And Kevin already mentioned this, but if patients kind of see that they're making progress towards a certain goal, it makes them feel good, right? They know they're getting back to what they like to do. They're happy with their care as it's going. So I think those are the main ones I wanted to touch on. I guess the other piece that I say a lot to my patients is that you had already said this, but first 3 months is when the most re-tears occur. So if you have one of these nervous Nelly patients that after 3 months are like, well, we can push a little bit more. This thing is probably healed down pretty good. And then when we get to the 6-month mark, like there's usually no tearing at that point. The large majority is going to occur 0 to 3, and 3 to 6, there's a couple. Then after that, usually most people don't re-tear, right? So once you get to that 6-month mark, like nervous Nelly, you're doing great, right? The likelihood of you tearing is very low. We can push a little bit more. But if you have someone who's like that macho man that overdoes it the first 3 months, you're like, whoa, you have a chance of re-tearing this, and you got to let them know that, right? And sometimes you're just like, again, repeating yourself over and over again with those folks. But
yeah, so number 3, a little repetitive here. We talked about this a little bit, but following the rehab protocol and getting the rehab protocol, right? So maybe when you call initially, if the patient shows up to that first visit and they don't have their protocol, maybe when you call the surgeon to ask about the surgical report, you're also asking if they have a specific protocol they want you to use. Because I've seen all types of variations here where people show up without a protocol, or they'll show up with their folder that has everything in it that you need. So both are great. But if you don't have access to the protocol, I think the first thing I would do is make sure that you have what the surgeon wants. Because even if there are other good protocols out there, which I think there are, and we have access to them, the surgeon might have a specific protocol that they like. And if anything were to happen, it could be on you for not following what this surgeon wanted. So I think that's important, is being on the same page with the surgeon and having their protocol. Sometimes what I find happens is that the surgeon will say, no, it was just a regular partial thickness cuff repair, kind of a small to medium sized tear. You can go ahead and just treat it like any other small to medium sized cuff repair. And, any other protocol you find on that might be fine, right? So in that case, one group of protocols that we're a fan of for all different types of surgeries is the University of Delaware. They have great protocols on their website. And I think those make a lot of sense. The other one, which we spoke about on a previous podcast, is that American Society of Shoulder and Elbow Therapists consensus statement. That's a great one too, right? So there
Link in
are,
show notes.
oh yeah. So there are good ones in, that you can find on the internet. And maybe if you pick one of those, you can just send them to your surgeon and ask, hey, can you look through this? Does this look like a good option for the patient? Is there anything you would add or subtract from this? And most surgeons, they're going to be willing to help you out on that because they also want to have successful patient outcomes. So I think that's a third big key is make sure you have the right protocol and it makes sense.
I agree with a lot of that. A couple things I had written down. If the protocol looks wonky, which it often does, right? And I can remember several surgeons I've worked with in the past that are just ultra conservative, right? And like literally, we weren't allowed to start isometrics until month 4, resisted range of motion, month 5. And that was based on some of those tissue healing times from animal models, right? It's like week 15, we don't have a good anchor of the tendon to the bone that's fully matured until about 5-ish months, 4 or 5 months. So he was basing a lot of his protocols off of animal models, which is kind of like, I don't know if that's completely the right way to go, but that was his reasoning. But you can often reach out to these surgeons, just say, hey, this patient's progressing really fast. We're not allowed to do X until month 4. Can we bump it up to 3.5 weeks or 3 months just because things are going really well? And oftentimes they'll reach out to you. They're like, oh, okay, no worries. Oftentimes, we already mentioned this, but they don't even know the protocol they're sending over or when they're allowed to start X, Y, and Z. So if you just call them up and ask, like oftentimes they're very cool about, yeah, it's fine. You can start that. Or maybe they'll tell you the opposite and say, you know what, this person, I'm really concerned they're going to re-tear. Let's hold off on this for now. And the other part too, and like, this is not necessarily what you ever want to hear, but if you're working with a surgeon and they trust you and all of a sudden you start kind of going against what they recommend, you might really destroy that relationship. And maybe that's okay. You might not want to work with that surgeon, but if you really do get business from a surgeon, you like that relationship, you don't want to screw it up by doing something that scares the crap out of a surgeon. If the surgeon hears you're doing something that they disagree with, like they're not going to send any patients your way anymore because now they're fearful. Like a lot of docs are already very fearful, physical therapists in general. And now they hear you're doing something wild. They might just kind of like, put the kibosh on that. One thing I do pretty frequently is that when patients are going back for their, like, let's say 6-week appointment or let's say 12-week appointment, I will send questions with the patient to ask the surgeon. And sometimes there are some question marks. Like a big one is, when can I start running after rotator cuff repair, right? When can I start like certain tasks that maybe are not on the protocol or you have some questions about, right? I'll ask a lot of questions to surgeons, like, when are you comfortable starting weight training or something along those lines? And just be prepared for sometimes like really weird answers that don't make sense, just because sometimes surgeons don't understand the nuances of rehab. So sometimes we're relying on the surgeon to drive the boat when they're not good drivers, right? They don't do rehab for a living. So I think listening to what they have to say makes sense, but also keep in mind that you're the rehab professional. You're supposed to be the one that can kind of critically reason this oftentimes better than the surgeon. So a few things to keep in mind there.
Yeah, and that brings us to key number 4, which again, I think we've hit on a little bit here, but I think this is the most important thing that we do as PTs is understand the patient's goals and help them meet those long-term goals, right? So early in rehab, we might be doing things that the patient doesn't see the relevance in, and they might get a little bit discouraged. But if we can tie that into their long-term goal of returning to whatever sport they want to return to, that's going to be the key to keep them on board and keep them engaged throughout the rehab process. And then, this relates to rotator cuff repair, but it also relates to any type of rehab. I think, Dan, you do a great job at this so talk to the patient and say, hey, let me make sure I heard you correctly, Sally. Your long-term goal after the surgery is to get back to tennis, right? So let me show you how we're going to get there. We're going to go through these steps for the first several weeks, and then we're going to go through these for these months. And then, hey, look, maybe around month 5, we're starting a return to hitting program. And that's going to look like this. We're working on a progressive swinging program based on how you're doing, taking a certain number of swings per day. And then, that tournament you have your eye on in 9 months, I think that's going to be attainable if everything goes smoothly. right? So then they're motivated throughout that whole process. Their goal is front and center. Um, they know that you're prioritizing getting back to tennis for them. That's what they want to do. They don't want to, and we see this a lot. I feel like in our clinic where we have patients that are so physically active, they've gone places where they never progress past, the dumbbell program or bands, and they don't see how they're going to get back to tennis after this rotator cuff repair because their goal was never explicitly stated in that initial evaluation. So you want to get it, you want to recite it to the patient. They can hear you say it. They know that you're prioritizing it. And it just makes that whole team way closer knit, and they know that you're really invested.
Yeah, those long-term goals are really important for the patient. Another thing too that is not necessarily related just to rotator cuff, but therapeutic alliance, right? We know that if you improve your therapeutic alliance, it's going to improve your outcome, improve the buy-in. All things we're going to be kind of improving if you do this well. But I think a big thing is that listening to the patient's goals, just like Kevin said, and then say, we have a plan to get you there. Here's step one, step two, step two, step three. Step two, three times, I guess, because I can't speak appropriately.
Step two is really important.
Step two, step two, step two, and then step three. But I think that patients really like that. I mean, it shows that you're listening to them. Like, okay, this person has really heard that I want to get back to this. Not only that, but they actually thought through a really systematic approach on how to do it. So I think that really helps to build empathy, therapeutic alliance. And now they have a really clear-cut path. It gets them kind of excited to continue with their rehab. They can see that they're working towards their goals. So a lot of positives that come with that, right?
And now that you're an expert with the rotator cuff, you might want to know some basic and easy exercises for your patients that have rotator cuff related pain. And above my head in the corner, I have a video for it. I want you to click on that and I go over my favorite beginner exercise if folks have rotator cuff related pain. Go ahead and click on that and I'll see you in that video. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.